Hello, from Japan. I'm Dr. Takashi Kon, and so I'm very interested. Also, I'm waiting for the exciting lecture.
Excellent.
Are you in a new place?
Hey, Ramesh.
Are you in the new place?
At the new place. It's really amazing. Amazing place.
Really?
Very beautiful. And these guys have so much infrastructure, you know. I mean, they're already a beautiful 1,100 bed hospital.
Oh.
They get 170 beds for neurosurgery.
Very good. Can't wait to meet you there.
Yeah, please. And these guys have fantastic conference halls, and you know, they have all the infrastructure. So
yeah. I'm glad you'll be back. I'm sure you'll be glad to be back in India as well.
Yes, absolutely. So we're keeping everything back in Nepal as it is, so that we can go for a holiday or something. But working in Nepal rather than Professor Goyal wants to be on the panel, it seems.
Pablo is Sanjiva is, I don't know whether Sanjiva can add.
No, Pablo's got control now.
Pablo is I think he's away from his desk. Hi, Ek.
Hey, good morning.
Morning.
Pablo, do you want to make me co-host or something briefly?
Dr. Takashi, hi.
Hi, good evening. Good evening. In Japan, after 9 p.m.
Whoa.
I'm expecting.
Keep strong. Keep strong.
Yeah, keep strong.
Ek.
Yeah, man.
Good to see you.
Lots of things happening. I'm in lockdown at home. I was traveling and I'm punished. I have to lock up in my basement for 2 weeks.
Oh, isolating.
Yeah, and they check on you in Canada. I got 2 calls from the government by phone and 1 email already to make sure that I'm not leaving the house, which is pretty insane. But I can't, you know. So I'm writing all these little ideas down that I have. I have my 1,000,000 books behind me that I can keep myself busy.
I think that's the only good thing about this isolation, and you get some time to do things which you never could manage.
No, absolutely true. Absolutely true.
Well, lockdown has been fantastic for me. So I worked on all the crazy ideas that I've been working on before. Earlier, I was just, I was not really interested. So we managed to make a prototype for the exoscope that we wanted to get in. So we're getting it into this place right now, and we'll be having it in the lab very soon.
Good.
Exoscope.
Exoscope, robotic exoscope.
Yeah. Pablo, could you add Atul to the panel?
Did you send him a link? Did you send him a link that can directly connect him to the panel?
Hello.
Now. Hi, Imad.
Imad.
Hi, everybody.
Today they want to the sun is right behind you. The sun is.
I was worried that I might not be connected. There was some problem with the internet. Everyone on board is Giovanni.
It's very sunny where you are.
I'm here.
It's in Dubai. I want to show you the tower, but you cannot see it from here.
It's very sunny.
How is everybody?
So you were asking about the link?
No, this is for Atul, to get Atul onto the panel.
Atul has to send, you have to send Atul a link that he can come to the panel.
You can just add him, can you, Pablo?
Let me do that. Yeah, he probably got an email. Atul, I'm just.
Will you send him a link, please?
Yeah, he received it probably. Let me do it now.
I don't know whether Vladimir in, but he sent me a message. He will be a little bit late as he was doing an AVM. I thought he would do it with his hand, so he would be fast.
Hello, Imad.
Hi, Jack. How are you? Good to see you. Now I'm seeing you on the screen. How is things? Florida is more shiny than Dubai.
Look at the sun behind you. But Imad, you should change your position because the sun behind you is...
Yeah, I'm trying to move
Yes, better.
There you go.
Better? Yes.
Jack.
And,
hey, Ipe, how are you?
Absolutely good. Jack, you don't seem to age at all.
Wonderful.
What's that? Ipe, what did you say?
You don't seem to age at all. I mean, from 2012, you don't seem to age at all. What is the secret? I mean, you don't have to tell me on the net in public, but
it's very easy. It's the secret is that your eyesight must be failing miserably. Quickly, go get your visual field test.
Oh, guys.
Thank you.
Anybody missing? Is Giovanni Boggi? He's
I'm here.
Moderator as well.
I'm ready.
Oh, hi. How are you?
Hi.
Giovanni? Good to
How
see
are
you.
you?
Good to see
I am
you.
checking Dubai for you, Giovanni. I am in
Okay.
Dubai now. We just arrived yesterday.
Oh, good, good.
I'll keep you updated. All right. So are we on time? Should we proceed? Vladimir will be later. I have the moderators and speaker. Atul is with us as well. Did we manage to get him?
Yes,
Is
yes,
it-
Imad. I'm very much with you, my friend.
Okay, okay. With the vessels, I can see you among the vessels. Are you the basilar or it looks like you are carotid?
I'm in a mess of mesh.
And a mesh, yeah. Okay.
Jack is smiling. He wants to see me in a difficult situation. Jack.
Atul, nobody can handle difficult situation like you. You have the determination of a bull and the intelligence of, I don't know, an angel.
Einstein.
Oh my goodness. Oh my goodness. Let's begin, Imad, before Jack becomes a little bit berserk.
Okay. And Victor, is he with us? I don't see he's on the panel. Victor Perez, Victor Hugo.
No, he is not in now.
Is he or not yet?
Not yet.
You could start with Atul, Imad, do you think?
He had some issues. Victor had some issues. He texted me because
okay.
GMT is fixed, but sometimes zones are changing at the end of October.
Okay.
That's why he will be a bit
No
late.
problem. All right. So with the start of the fall, we'll commence with the course, and I'm glad to have slate of stars with us.
You know what, Imad? Can I,
Yes?
I have to go for 5 minutes. I had kept, can I, can you excuse me for 5 minutes or I have to start?
Sure.
Well, I think we'll give you the 5 minutes.
Just I'll return in 5 minutes because I had not thought Victor will not be here. So,
yeah, okay.
So I will join you in 5 minutes. Is that okay? Jack may start the show. Jack, is that okay with you?
Perhaps I will start with Jack. Are you willing to start?
I can start, no problem.
Okay, let me give an introduction, and we are going. Today is the schedule a little bit messy because of connection. I have to apologize for that, but I think we have a good presentation for this seminar. I would call it because they have key speakers from around the world, from US and Canada, and from the other areas, and from Oxford. And before I start, I'll give the 5 minutes. I want to show you the mask we use in this place, and I'm sure Giovanni would like this mask.
Oh, that's
We have,
that's Venice.
We have
That's
the stars
Venice.
with us. We will have a fiesta in Florence. So we will start. We have to make fun a little bit sometimes. Without further ado, I'd like to ask Professor Jacques Moncus, a friend and a pioneer neurosurgeon, to share his expertise from Miami. And the venue is for Jack. He is the chair there, and he is the program director for the vascular. He has many ranking in the World Federation, and in a great educator. He has been an invited speaker to many webinars, and we were privileged that he accepted our invitation to talk about the cavernous sinus, a new insight into the cavernous sinus. Jack,
hey,
the podium is
thank
for
you, Imad. It is not allowing me. It says the host has disabled slide sharing. Somebody needs to allow me to share slides.
Pablo?
Yes,
Oh,
it's done
now
already.
it works. Now it works. Thank you.
Yeah, did it.
Okay, well, this is so nice to see everybody. Do you see my slide?
Yes.
Okay,
exactly.
great. It's not the same as being in person, but this will do, I think. Let's see, to advance. Well, I have to thank Imad and Vlad for putting these remarkable series of neuroanatomical seminars together and help so many people who are hungry for education around the world. Of course, they both have tremendous history in education. There is Imad in one of the many courses he's been involved. And clearly Vlad has an interest in heads and books. And here he is, I think it's a magazine publication. I'm not sure what the article was about, but studying somebody's head. So the deeply rooted tradition in neuroanatomy. Well, I'm talking to you from beautiful Miami. My disclosures are irrelevant. The first two are irrelevant, but the third one I think is very important. Passion for microsurgery, cerebrovascular surgery, skull base, neuroanatomy, and debating my friends. So that's what I love to do most of the time. So here is the outline for the 20 minutes presentation. I want to, cavernous sinus will show you very well how cerebrovascular and skull base are inseparable twins. I will then show you case examples of both, and then I will conclude. Let's start with how those two fields, cerebrovascular and skull base, are intertwined. Are they inseparable twins because they want to be inseparable twins, or because they have to be inseparable? Well, I believe that they have to be inseparable. These are some names of masters of both cerebrovascular and skull base, and of course there are many more. These two fields, the yellow boxes and the red boxes, overlap, as you well know, for the last several decades, and this is how they intersect, as you know, with our disciplines that we work with, stroke neurology, oculoplastic. You can see how cerebrovascular and skull base spheres overlap. Why do they overlap? These are some examples of how they overlap. Cerebrovascular helps skull base. How? ICA balloon test occlusion for tumors, pre-op tumor embolization, repairing arteries and veins when you're doing a tumor resection. The microvascular skills you acquire from cerebrovascular help you dissect, manipulate, and respect the brain. And the other way around too. Skull base, if you have an appreciation of anatomy, surgical exposure, you know when to have just enough, maybe not enough, or maybe too much exposure, and all the toolboxes you learn. And also, I think the people who do both, they have or have something in common. There is a surgical skill in neuroanatomical knowledge, delicate microsurgery, similar dissection techniques, probably high and hopefully high capacity for mental focus, stamina, creativity, and adaptability. So these two twins are really meant to be, to be together. As I said, CV at the service of skull base. In these examples, handling veins, handling arteries, and skull base at the service of CV. And the cavernous sinus is a perfect example of that. So some twins are meant to be separated, but I think CV and skull base are meant to really live in harmony forever. Which brings me to the topic of today, the cavernous sinus. I only have 20 minutes, so I really have no time to go over the history, the very rich history, except to mention, among others, the contributions of Hakuba back in the 80s, early 80s. Dolling's approach, of course, ushered what we call the modern area of cavernous sinus surgery, with his 2 landmark papers of 1985 and 83 before that. And that started the conquest of this so-called no man's land. This is El Capitan, the most difficult mountain to climb in the US. A lot has been written about it. But what I want to tell the young people in the audience, cavernous sinus surgery is not like, should not be free soloing like the famous Alex Honnold has done on El Capitan. No ropes, no safety, remarkable feat. I think if we do our job as educators and teaching everybody how to handle the cavernous sinus, anybody can do it. Any neurosurgeon can do it. Like Sela Schneider, the 10-year-old, she's doing El Capitan climb, but she's doing it the smart way with safety measures, ropes, helmets, and so forth. Cavernous sinus surgery should be like that. It's not a cowboyish attitude. Let me infuse a little anatomy into it. This is, I've written with my co-authors this paper many years ago, modifying the anatomical approach to cavernous sinus. I found it more easier to teach residents and fellows to modify the Doleng technique. And what I mean is Doleng described peeling, cutting the frontotemporal dural fold, but many trainees don't really understand it in 3 dimensions. So we modified it and we switched the steps. So you see the bottom right, we peel the lateral wall of the cavernous sinus before cutting the frontotemporal dural fold. My pointer isn't showing, but that's okay. You can see the anterior clinoid before you cut the frontotemporal dural fold. I find this very useful in teaching young trainees. So this is a cadaveric dissection from our lab here. And this is the peeling. You can see V1. You can see the anterior clinoid from the middle fossa. Then you can cut the frontotemporal dural fold. Of course, this is a further dissection of the contents of the cavernous sinus. And the orbit, of course, superior orbit of fissure, cavernous sinus, the orbit are all in continuity. And you need a proper understanding of all that. Now you can see the anterior clinoid, and in a surgical case, you can drill it if that's what the purpose of the surgery is. And after drilling it, you can see the optic strut separating the optic strut, which is immediately in front of the clinoidal segment of the carotid artery, just below at the optic nerve floor, and the 3rd and 4th nerve lateral to that. So that will give you a good appreciation. Many times, cavernous sinus surgery is combined with so-called Kawase, again, because really Hakuba also contributed tremendously to the understanding of what we then called Kawase approach, the anterior petrosectomy. And we need to understand the cochlea. And this dissection is, of course, from Roten. You need to understand the arcuate eminence. You need to understand the course of the facial nerve. And I think Sébastien may be speaking after me about this in more detail. Geniculate ganglion, and these are all the segments of the facial nerve. There is a tympanic cavity, the ossicles would be here. This is a more focused dissection on the cavernous sinus and the anterior petrosectomy, anterior petrous dissection. You can see GSPN crossing over the horizontal petrous carotid. You can see above that, I'm sorry, I'm not sure why my pointer doesn't show up, but the basal turn of the cochlea. Below that in the picture is tensor tympani, and just below that is eustachian tube. So you can see the parallel arrangement of GSPN, petrous carotid, tensor tympani, eustachian tube. This is from a recent surgical case approaching the cavernous sinus region and the Kawase area in a combined way. I'm going to start by summarizing my surgical bias in the sense of what approach to select for cavernous sinus lesion. If the lesion is localized to the cavernous sinus, then I usually do a so-called Doleng-Hakuba approach. You can go to it pterinal, you can go to it subtemporal. But if the lesion is both intra and extra cavernous, I usually choose the extra cavernous portion as an entry point to the cavernous sinus. So that can be anywhere, like the list of areas that you can see here. Orbit, infratemporal fossa, the sella, for typically a pituitary adenoma invading the cavernous sinus. You go endonasal endoscopic and so forth. So let's go through case illustrations, discuss a little bit the anatomy. And Imad, I'm not keeping track of time. Do you mind maybe interrupting me 2 minutes before you want me to finish? Is that okay, Imad? Oh, okay. All right.
Yes, no problem.
Okay. Vascular lesions. So the tiniest way you can enter the cavernous sinus is when you want to get a little bit more exposure for top of basilar aneurysm. For example, this SCA aneurysm that is low, you can see it is low below the posterior clinoid. You can see its wide neck. So I'm doing a subtemporal approach. Left side, I'm seeing the fourth nerve, cisterna ambiens. And you can see in the bottom image, I can see the aneurysm, but I have no proximal control. So you can just mobilize the back of the fourth nerve. You can just drill the tip of the petrous apex. You can pack it with a little bit of Surgicel as you get some cavernous sinus bleeding. When you do that, you can see in the picture on the right, the proximal basilar in the picture is above the fourth nerve. You can see it. Now I have proximal control. So and then you can clip the aneurysm under temporary clipping. My point is, this is probably requires, of course, knowledge of posterior cavernous sinus anatomy, petrous apex region. And this is just a minuscule entry into the cavernous sinus. And of course, it'll go more and more as I show you more examples. A complete anterior clinoidectomy, of course, is required for superior and for ophthalmic artery aneurysm, superior hypophyseal artery aneurysms, as can be seen here. And unless you understand the roof of the cavernous sinus, you cannot do a proper anterior clinoidectomy, as I showed you in the earlier anatomical cadaveric dissection. This is the opposite side ophthalmic artery aneurysm on the same patient, and of course by drilling the clinoid, in this case intradural. I generally drill clinoids intradurally for aneurysms and extradurally for tumors, because you don't know if you need to drill the clinoid until you see the aneurysm. So I make that decision after exposing it. I'll go very quickly on this ophthalmic artery aneurysm. What I want to show is clinoidal drilling is, yes, it is simple, but you still need in some aneurysms that are so-called junctional, such as here the distal dural ring, you need to enter a little bit the roof of the cavernous sinus, get into bleeding. Here we have proximal control in the neck, and then you can deflate the aneurysm to minimize trauma to the optic nerve. So this is anatomical knowledge being applied for safety. So look how the aneurysm deflates. So I don't have to really mobilize the optic nerve too much. And then you gain space, your temporary trapping of the aneurysm. I use the Yazergil technique sometimes of coagulating the aneurysm to shrink it further. And then you can place the clip. But again, here is roof of cavernous sinus. You have to cut sharply the distal dural ring to untether the aneurysm and then put, in this case, 2 clips. So again, small amount of entry into cavernous sinus for most of these aneurysms. How about basilar tip aneurysm? Look at this basilar tip aneurysm. Yes, I know we are in endovascular area, but as I will show you, particularly in the next case, you still need to know how to do these because endovascular can fail. Wide neck basilar tip aneurysm. So this is half and half approach, anterior clinoidectomy. Here is a clinoid, extradural in this case, because I know I'm going to need to drill it to get a half and half approach and partial transcavernous approach. Here is a carotid artery clinoidal segment at the tip of my sucker. and then intradural, Sylvian Fisher splitting. You saw the aneurysm right here, and then you have the room to clip the aneurysm. And here is the post-op CTA. This is a recent case that failed endovascular, basilar tip, giant aneurysm, coiled and recoiled. Here it is, coiled and recoiled. And by the way, you can't see it, there is an enterprise stent into the basilar and the left PCA. So you cannot put a flow diverter. At least my endovascular partner said it's not doable. Patient getting worse. What do? That's what we're dealing with these days when endovascular treatment fails. So it requires a transcavernous approach. I will show you some of the peeling of the cavernous sinus. This is the intradural portion. Okay, so here, carotid artery. Here is the third nerve intradurally. I've already done the Dolling technique. Now I'm going to extend it intradurally. Here is optic chiasm. You need room to deal with these cases. Here we go. So unless here is venous bleeding from the cavernous sinus, unless you understand the layers and the arrangement of the nerves, you cannot obviously do this operation. So now I'm mobilizing the oculomotor tunnel by cutting the dura, the carotid oculomotor membrane. You peel back, and you peel back on the fourth nerve. I like to use this sharp disposable sickle knives. Here is an excellent view of the posterior clinoid. Here is the third nerve. You keep cutting back. My good friend Ali Krisht has wonderful, many such videos of approaching the basilar tips. It's very standardized. You peel this. There is a fourth nerve now. I've mobilized the third. I mobilized the fourth. Look at the beautiful view of the pons that we have. Here's the fourth nerve. Now you have the maximum room you could need. Sometimes it's not enough, but that's the maximum you could do. Now you drill the posterior clinoid with this. I love this drill because it's protected all the way to the ball, and it's curved and it's low torque. So it's not hard on your hand. Then I put the retractor. Now, at last, I have proximal control of the basilar. It's impossible to do this case without transcavernous. And of course, I'm not going to bore you with trying to clip it, but here I cut the PCOM. Of course, I tried to clip it without opening it. I could not. The coil mass kept pushing me. Then we opened it. Trapped it. But please notice, how can you see had I not done the transcavernous dissection? Now I've opened the aneurysm, and then you have room to clip below the coil mass by untethering the coils partially. Excellent use of cavernous sinus. Here is a post-op of cavernous sinus approaches. Pituitary adenomas, I don't need to tell you that, of course, if they invade the cavernous sinus, particularly if they're functional secretory adenoma, you chase them from endonasal endoscopic, such as this case. You can see how high up into the roof of the cavernous sinus you can get. Many other examples. This is a dermoid tumor of the cavernous sinus. He has, as you can see, a partial third nerve pre-op. I want to show you the scan. Here is a scan, classic dermoid tumor of the cavernous sinus. Of course, very easy to remove because it's soft and fluidy and it has hair in it. But the key is to liberate it completely from the cavernous sinus. I will take you straight to the view at surgery. Here is the anterior clinoidectomy. There is, I like to use the Dolling technique of pulling the dura, usually no self-retaining retractor, pulling the dura of the frontal and temporal lobe. And now the Dolling Hakuba peeling begins. Don't enter the dura, but just peel the layers. You can see peeling the layers, Here is V2 down. Beautiful view of V2 at rotundum. Here, let me show this. Here we go. Periorbita V2, frontal lobe dura, temporal lobe dura. That's a classic Dolenk exposure. Now you can enter the lesion after doing monitoring and stimulating of the, you can see the whitish dermoid material. And then, of course, you stimulate the nerves to make sure you go within the triangles. And there is even a piece of hair. And then I will Doppler the carotid artery intracavernous, and here between V1 and V. This actually between V1. This in the Parkinson triangle to V1 and 4. Here is the carotid at the depth. I'm Dopplering it, and that's a closure. And post-op, he is exactly the same. He does not have a complete ophthalmoplegia at all. And here we are examining the eyes and so forth. Of course, swollen eye because of the cranio-orbit approach. Schwannomas. Here is a patient presenting with a orbitocavernous schwannoma. You can see what it's done to her eye. And I'll show you. Here is a lesion in the orbit. I have another talk about why neurosurgeons need to know orbital anatomy as well and do orbital surgery, but this is in the orbit going to the cavernous sinus. What I want to show you quickly, here is the anterior clinoidectomy. Then I will resect, here is the optic canal, decompressed. Now I will go for the orbital part of the tumor first. That's kind of the easier part. This video is sped up. So we will remove this. Now, then we do the cavernous sinus peeling. Here is greater wing of the sphenoid, peeling the dura like I showed you in the last case, peeling backwards till you go behind the posterior limit of the schwannoma. Here is the bulging schwannoma in the cavernous sinus. So obviously it's crossing the superior orbital fissure. Use tissue sealant to stop venous bleeding, monitor the nerves, do exactly what I just showed earlier. Here is V1, you're opening lateral wall of the cavernous sinus, and it's a schwannoma. It's very easy. It's soft. You can peel it. And almost, I mean, not quite one piece, but almost one piece removal. You tease it out. It has a wonderful plane, and that you can see it between the nerves. And these patients do not have permanent cranial neuropathy from cavernous sinus surgery because it's a schwannoma. Meningioma is a different story. And as I will show you in the next case, I am not as aggressive with hollow cavernous meningiomas, obviously of the cavernous sinus, unless they're particularly soft, which is rare. Here is a post-op scan. Meningiomas, all I'm going to show you is an exception. This is a hollow cavernous meningioma that happened to be soft. So I took it out completely. You always go in with the intent of peeling the cavernous sinus and checking how soft is the meningioma. Most of the time, if they do not have an ophthalmoparesis, I do not believe they should be removed aggressively from the cavernous sinus. Chondrosarcoma, same story as schwannoma, very soft. Look at this one. It's all over the paranasal sinuses. It's in the cavernous sinus. How should we do
sorry,
that?
Jack, 2 minutes.
2 minutes, perfect. So there, following the slide I showed you earlier, you go endonasal endoscopic into the cavernous sinus. And that's what we did. I don't have time for the video. This is post-op. The chondrosarcoma is soft. And in all of these cases, it's not simply anatomy that dictates the approach, but it's pathology. It's an interplay of anatomy and pathology. This is another chondrosarcoma. How would you do it? It's all over the cavernous sinus, middle fossa, posterior fossa. Here it is on CT scan. Well, this case needed a combined posterior petrosal and anterior petrosal. Here it is pre-op. Here it is post-op. And here she is 5 years post-op with no recurrence at that time. Chordomas, this is, I'll show briefly. may be controversial, but this is a massive chordoma of the clivus invading the cavernous sinus. Look at it here. Now, most clival chordoma I remove endonasally, endoscopic, but this one, look, it's splitting the brainstem all the way to the fourth ventricle, and it's in the cavernous sinus. So what I did in this case, I did the opposite. I did the transcavernous, transcranial approach first, and here is the approach. And here is a Kawase combined with transcavernous. Here, I'll show you the schematic of it. Here is the schematic of the Kawase. I removed the part that's intracranial because of the basilar artery perforator, which you will see. Here is a soft chordoma, but you will see there are many perforators. Here it is where we are. This is a beautiful view of the cavernous sinus, skeletonized. Look at the perforators. I would not have been able to do this properly endonasally. So I removed most of the tumor this way, then I came later endonasally. And this is the endoscope added assisted endoscope. Let me go to my conclusion since we are running out of time. Here are my concluding remarks. It is fiction that all cavernous sinus lesions are created equal. Location does not trump pathology. Cavernous sinus is definitely accessible. Surgical morbidity is not certain at all unless you don't apply judgment. It is a fact that cavernous sinus surgery is harder, riskier. You need to understand the anatomy. It is okay to use so-called profiling in choosing your patients and your lesions, which ones to approach. Remember, lateral wall is not intracavernous. Meningiomas of the lateral wall of the cavernous sinus, piece of cake, they're not intracavernous. And of course, you need judgment. And we, of course, have to thank this guy with the red arrow for having popularized this a few decades ago. Thank you very much.
Well, thank you very much, Jack. A wonderful overview of the cavernous sinus surgery with a lot of educational highlight and marking. And I was checking the chat. There was not a single question. All they said their greeting to the speaker. Yeah. And I leave it for the panel. I can take one question from the panel. I'm seeing Sebastian joining us. Hi, Sebastian Fröhlich. He just managed to get in. And please, any of the panelists would like to...
Can I just ask one question, yeah. Jack? It's Ramesh from London.
Yes.
The last case, did you do the endoscopic approach straight away or after some time?
No, after some time. I waited a few weeks for everything to settle down. The clival chordoma, you mean?
Yes.
Yes, I waited for some time. Then I did a few weeks. Then I did the endo. I didn't show the second part, endonasal, removed it gross totally. Then we went to proton beam, and she remains well. This is about 2 years ago.
Okay, thank you.
Any other comment or questions?
Me, Ima.
Yes.
Jack, I just want to ask, what's your take on primary radiation therapy for strictly intracavernous meningiomas not arising from the lateral wall? We see more and more patients that are being referred from the radiation oncologist after they had the first round of radiation to the cavernous sinus, because even without seeing a neurosurgeon, they get straightly referred to radiosurgery because of that, morbidity aspect and the convenience aspect. But all of us know post-radiation resection is significantly harder than if you get them naive.
Yeah, I mean, it's a wonderful question. I'm a very aggressive surgeon, but if the meningioma appears fibrous, particularly if you use MRI elastography, it's purely intracavernous and has minimal ophthalmoparesis. My choice is gamma knife if it is small. It's tough to, and I have a gamma knife practice, not a huge gamma knife practice, but I treat my own patients. I think we do better. Now, what is underappreciated is what Bill Caldwell in Utah has talked about, and I've done many such cases, cavernous sinus decompression without actually removing the tumor. You can, particularly if they have ophthalmoparesis, many of them do improve. You know, I don't know, you know, so I've done a lot of that too, but it is very hard to defend the point of aggressive resection of hollow cavernous meningioma. I mean, unless they have significant ophthalmoparesis or they fail. I skipped a few patients. Some of them are WHO grade 2. You're trying to save their life. It keeps recurring. I have several cavernous sinus exenterations of very tough meningiomas. Yeah.
Yeah, thank you. Same concept.
All right. Yeah. If no further question, we'll move to the original listing of the program. Thanks, Jack, for the wonderful presentation. I'd like to ask Victor Hugo, our colleague from Mexico, to give his presentation. He's with us on the webinar now. He will talk about intercavernous carotid and its vascular branches.
Thank you, Ayman.
Victor?
Thank you so much.
Thank you.
Let me share my screen. Can you see it? All the screen?
Yes.
Okay. Okay, I'm going to talk about branches of cavernous sinus artery. Cavernous sinus is difficult to go because of arteries, nerves, and most of the approach used to go for cavernous sinus is pterional approach. Here we have the Sylvian fissure and the middle cerebral artery. And here we can see the anterior clinal process.
Your slide is not moving. Go into presentation mode, please.
Excuse me?
Go into presentation mode and
okay. Is it okay?
Yes.
Okay. The parietal cavernous sinuses are located near the center of the head, on each side of the sella, pituitary gland, and sphenoid sinus. Each sinus has dural walls that surround a venous space through which a segment of the internal carotid artery courses. The sinus extends from the superior orbital fissure in front to the area lateral to the dorsum sellae behind. This is dorsum sellae, third, fourth cranial nerve, fifth. Here we have optic nerve and supraclinial carotid artery. This is a dissection in which I removed the pituitary gland in order to see some arteries, for example, this, the inferior hypophyseal artery. This is another picture of brain injected in situ with latex or silicone. We can get very nice specimens in order to make exercise with anatomy dissection. The cavernous sinus is defined as the dural space in which the cavernous segment of the internal carotid artery courses and contains not only the cavernous carotid artery, but also a venous confluence that receives veins draining the orbit, Sylvian fissure, and middle and anterior fossa, and has free communication with the basilar, superior and inferior petrosal and intercavernous sinuses. The ophthalmic artery commonly arises just above the upper ring from the medial half of the anterior wall of the internal carotid artery. From its origin, it runs anteriorly and laterally on the upper surface of the optic strut and below the optic nerve. The ophthalmic artery may also arise in the cavernous sinus or from the clinoid segment, in which case it usually passes to the superior orbital fissure. It may rarely arise from the middle meningeal artery. Let me show you this video in which we could not find or could not, we didn't see the ophthalmic artery in the left side. This is right side. Here we can see the origin of this ophthalmic optic nerve. And after dissection in this part of the cavernous sinus, we didn't find the origin of the ophthalmic artery. So this is tear nerve. So we try to localize the ophthalmic artery, but we didn't find that. For example, let me later we are going to talk about the McConnell artery. This is a small artery that is coming from the medial wall of the cavernous artery. This one, McConnell. Okay. This is the superior view of this cavernous sinus. Here we have the oculomotor, the trochlear and ophthalmic nerves coursing the lateral wall. The intracavernous carotid, intracavernous branches. Here we have the meningohypophyseal trunk in this part. The most proximal intracavernous branch arises lateral to the dorsum sellae. Here we have dorsum sellae, or just before the apex of the first core of the intracavernous carotid, where it turns forward after leaving the foramen lacerum. It is approximately the same size as the ophthalmic artery. Here we have the lateral wall after peeling the dura in this part. Here we have some arteries that are coming from the inferolateral trunk of the cavernous sinus. The third and fourth nerves enter the dural roof of the cavernous sinus just above us or slightly behind the trifurcation of the meningohypophyseal trunk. The meningohypophyseal trunk divides near the roof of the cavernous sinus. Parkinson noted that spontaneous carotid cavernous fistulas, which are presumed to be due to aneurysm rupture, tend to occur at the junction of one of the branches with the intracavernous carotid. Traumatic fistulas due to tears of the carotid and or one or more of its intracavernous branches may have several sources and are commonly located anteriorly in the sinus. Another artery, larger than the meningohypophyseal trunk that may pass through the cavernous sinus, is a persistent trigeminal artery. This artery arises from the carotid artery in the cavernous sinus proximal to the origin of the meningohypophyseal trunk and joins the basilar artery between the superior cerebellar and anterior-inferior cerebellar artery. The meningohypophyseal trunk typically gives rise to three branches: the tentorial arterial, also known as Bernasconi Casinari, which courses lateral to the tentorium. The inferior hypophyseal, which travels medially to supply the posterior pituitary capsule, and the dorsal meningeal artery, which enters the dura of the posterior sinus wall and supplies the clival dura and sixth nerve. The artery of the inferior cavernous sinus, also called the inferolateral trunk, may infrequently arise from the meningohypophyseal trunk. Here we have the meningohypophyseal trunk. This is the meningodorsal, tentorial, and this is the inferior hypophyseal artery. Roton described this meningohypophyseal trunk as the middle size or as an equal size of the ophthalmic artery. But in our dissections, we have found that this meningohypophyseal trunk could be very thin, like in this case. Here we have the meningeal dorsal artery, and these are small branches. Maybe this is going to the pituitary gland, and this is the inferior hypophyseal artery. Here we have the inferior hypophyseal artery. This artery anastomosis with the opposite inferior hypophyseal artery. This is an anterior and superior view of this dissection to understand this complex anatomy of cavernous sinus. The tentorial artery, the most constant branch of the meningohypophyseal trunk, is present in 1% of instances, passes forward to the roof of cavernous sinus, and then posterolaterally along the free edge of the tentorium. This is tentorial artery, and these are some small meningeal dorsal arteries. Here we have another picture. I like a lot this view. Here we have the pituitary gland, the intracavernous portion of the carotid artery, and here we have another small arteries that are coming from this cavernous artery. The dorsal meningeal artery arises from the meningohypophyseal trunk in 90% of cavernous sinuses. It passes posteriorly through the cavernous sinus with the abducent nerve to reach the dura over the dorsum and clivus. The inferior hypophyseal artery, the least frequent of the three common branches of the meningohypophyseal trunk, in 80% of cavernous sinuses, it passes medially to the posterior pituitary capsule. And lobe and anastomosis with its mate of the opposite side, after supplying the dura of the cellar floor, it may supply pituitary adenomas and tumors of the sphenoid sinus. It may also arise directly from the intracavernous carotid. Here we have the adenohypophysis and the neurohypophysis in this way. The inferolateral trunk artery of the inferior cavernous sinuses arises from the lateral side of the mid portion of the horizontal segment of the intracavernous carotid, approximately 5 to 8 millimeters distal to the origin of the meningohypophyseal. It arises directly from the carotid artery in most of the cases, and from the meningohypophyseal artery in another 6%. It passes above or below the sixth cranial nerve. Here we have the sixth cranial nerve, and downward medial to the first trigeminal division to supply the dura of the inferior lateral wall of the cavernous sinus and the area of the foramina rotundum and oval. It may anastomose with the middle meningeal artery at the foramen spinosum. Some branches pass to the trigeminal ganglion. We have made also some dissections, putting these small specimens in chloro in order to degrade the tissue. And here we have some results. Here is the intracavernous portion, and here we have some branches. This is ophthalmic, and this is meningohypophyseal trunk. And look, the size in this case is thinner, smaller than the ophthalmic artery. The McConnell's capsular artery arises from the medial side of the carotid artery and pass to the capsule of the gland or the dura, lining the anterior wall or floor of the sella. They are frequently absent, being found in approximately a quarter of cavernous sinus. They arise approximately distal to the origin of the artery of the inferior cavernous sinus. Some run medially in the dura, covering the sellar floor and the anterior lobe of the pituitary, and anastomose with the branches of the inferior hypophyseal artery. Here we have the medial wall of this intracavernous carotid. The cavernous sinus has a wide posterior dural wall that it shares with the lateral part of the posterior wall of the basilar sinus. Here we have the posterior part, anterior, and the junction between petrous portion and intracavernous. Here we have the sixth cranial nerve and the Dorellos canal. Thank you so much, Ahmad and dear friends.
Thank you very much, Victor. Nice preparations and insight into cavernous sinus carotid vascular supply. I'm not seeing any question on the chat. If any of the panel would like to give a comment on this.
May I, Imad?
Oh, sure.
Victor, as usual, is brilliant. Can't imagine the dissection you did. Beautiful dissection. I just want to ask about the McConnell's artery. You know, I wonder when we do endoscopic pituitary operations, and sometimes you worry about catching a branch of the carotid in the cavernous sinus. I often used to wonder whether this is the bleeding from the McConnell's artery, which often comes medially towards the pituitary gland. They're not as bad as the direct carotid injury. I suppose you could often control them without much problem. But do you have any thoughts on this McConnell's artery, which is, you said it's not very constant. What is your view on it?
Well, in my experience, I have not seen this artery in removing pituitary adenomas, but also this is not frequent. In only some cases, we can see this artery. Of course, if we have a tumor, like a pituitary adenoma, we could have not a thin artery, also a bigger artery. I have not found that artery in my cases. Okay. Only in dissections.
Okay, thank you.
Thank you.
May I?
Yeah.
I would like to make a comment. Thank you for this wonderful presentation and a suggestion for young neurosurgeon and not so young neurosurgeon to reach the ability of what Jacques Marcus showed us. You have to learn what Victor showed today. Go back to the lab and to the cadaveric lab before going into the cavernous sinus. So that is a lesson that we learned today. Thank you.
Very important message. Well, is Atul with us now?
Yes.
5 minutes. We gave you 25 minutes. So without further ado, Professor Atul is known for everybody, a pioneer in pituitary and skull base and spine. He was in previously invited speakers to the this webinar, and we are privileged to have him today talking about dura and tumor and the cavernous sinus and the surgical implication of it. It's yours.
Thank you. Thank you, Imad. Thank you, Vlad. And I see several friends, several respected and wonderful friends in the audience. So I am going to talk to you about my lifetime work on cavernous sinus. Cavernous sinus is a subject of my great interest. And if you see my first slide, dura mater. Mater means mother. I've been talking about mother for a long time. And recently I've lost my mother, but my lectures hopefully will go on for some more time. So many of these articles I have discussed earlier in the literature. Sorry for this. In this book in 1996, I published. So I'm working with cavernous sinus for over 30 years. And in this book, most of the work was on cavernous sinus has been published, and Imad knows about my work and many of you know about my work. So I'm here to just summarize my thoughts. There are many articles which are very fantastic, beautiful articles, which I wish at least the young people can read. And many of these are on speculations, on philosophical issues, on role of cavernous sinus in eye movements, role of cavernous sinus in eye health, and several other things, role of cavernous sinus in regulating the pituitary gland, role of cavernous sinus in regulating the body heat and body temperature, and so many things. So here are some of those articles. Most beautiful things which I mention in my papers is one is that cavernous sinus has a great role in eye movement and a great, wonderful role in vision. And over the years, there are several articles on surgery of cavernous sinus, and I wish you have an opportunity to read them because many of these articles are quite old, more than 25, 30 years old, but they have been quite popular and very well cited. You will be surprised, Imad, and you know about this, that I got this word from Arabic legacy, alum al-dimag, and Sam al-Mefti was very happy to hear my first presentation, which I gave more than 30 years ago. Alum al-dimag is from Arabic world, and it means that meninges are the mother of brain. So dura mater word came later, Arabic word came much, much before that. So dura is indeed durable. And if you see, the whole brain is in a compact dural cavity. There is a whole world of zoo in the nasopharyngeal cavity in the ear. So many microbes, but the dura keeps this whole cavity sterile. This is impermeable. Nothing can enter into the dura. No coronavirus has ever been reported to enter into the brain. So this is a compact. And this goes along the nerves, along the vessels, this dura goes. This has to be understood very nicely. So cavernous sinus is located by the side of pituitary gland, by the side of paranasal sinuses, and it is a compact cavity. It is extradural and within the dura. So it is both extradural and within the dura. These cranial nerve 3, 4, V1, V2 are having their own dural compartment. And this has to be understood, very fantastically understood. So my experience in cavernous sinus surgery, you see 1993, I did this case with extensive pitosectomy and extensive exposure. 1995, so 25 years ago, I did this case with very radical resection. 1995, I left this tumor behind. There was no gamma knife. There was gamma knife at that time, but there was nothing given to this particular patient. This is another patient which I operated 23 years ago and several years ago, quite well and quite asymptomatic. So we have to learn cavernous sinus surgery. You cannot say, I don't want to learn cavernous sinus surgery. Cavernous sinus surgery is philosophy. Cavernous sinus surgery is anatomy. Cavernous sinus surgery is art that we have to understand. So for your information, this was the first article in the literature on extradural approach to intracavernous sinus tumors. Of course, Vinko Dollens described intracavernous aneurysms. He described extradural approach. He also described trigeminal neuronoma extradural approach. But this article, intracavernous sinus tumor, in 1997 was the first article in the world literature. So I want to give you some tumors. This is intracavernous hemangioma. This is the only tumor which is primarily intracavernous. So as it grows, it respects the dura. It does not transgress the dura. It goes towards the sella through intercavernous dural connections. So this is completely within the dura. It goes towards the orbit, goes towards the Meckel cave, and it is absolutely benign tumor, but absolutely difficult to resect because it is very heavily vascular. And in 1991, I did this about 30 years ago, and this was among the first cases in the world literature where preoperative and postoperative images were shown in the published article. So this respects the dura. No matter how big it becomes, the dura lateral wall remains, Meckel cave, orbit, goes towards the sella, intercavernous connection, carotid arteries encased, heavily vascular tumor, and there is angiographically occult, and you have to remove because there are select indications. So in 2000, we described extradural approach to cavernous hemangioma on the premise of these dural connections. So these are extradural. Dura remains intact. You have to come like this. These are benign tumor. Brain is not tight, and you can come extradural, open the dura, open the lateral wall. Between the trigeminal nerve, you have to dissect, and you have to remove these tumors. So 2000, we described. Now we have experience of 39 or 40 cases, and which is quite a large experience. These are not very common tumors. So this is another tumor you can see towards the sella, lateral wall respected. It respects the mother dura. So this is one video which I will not show. So you see, this is preoperative. There is third nerve weakness. There is lateral nerve, and you can restore the vision. You can restore the eye movements. And this is the only treatment. More important is you can bring the smile, because there is huge headache in these patients of cavernous hemangioma. So this is another case I would like to briefly show you, because I sometimes run over the time. And this is gasserian ganglion, extradural exposure. I'm opening the gasserian ganglion. So this is a transgasserian ganglion approach for these tumors, which are completely intracavernous sinus. That has to be understood. So you have to then work. You see, this is intracavernous carotid artery, very heavily vascular tumor. You have to resect the tumor. You have to control the bleeding, and it can be done beautifully. You do it, you cure. Absolutely. Sixth nerve has to be protected throughout the operation. And of course, I don't have time to go into technical details of this subject, which is a very beautiful chapter of cavernous sinus surgery. So this is pre-op and this is post-op. Now I want to go and show you how the pituitary tumors behave with the dura and how they respect the dura. And believe me, some of these work which I am presenting, which is heavily published, has completely revolutionized pituitary tumor surgery. And you will ask me how. Let me show you how. So these are the pituitary tumors which can grow huge sometimes, but they remain benign. They remain benign, and if you resect, you can give new life to these people. They are not cancers. They are benign. First important thing that we described for the first time in the literature 25 years ago, that pituitary tumor, as it grows, it elevates the dura along. This is the diaphragm celli dura, which can go, which is elevated. So there is nothing within the tumor. This concept has completely changed pituitary tumor surgery. Otherwise, 25 years ago, all these tumors were operated transcranially. So there is a dura. So you remove the tumor, the dura will ultimately land into the picture. This kind of nubbin is also dural nubbin. It is not intracranial, it is not intradural. This nubbin is within the dura. So you have to understand. If you have to resect, you have to understand. It is not inside the brainstem. Of course, it is inside the brainstem, but there is a dural protection. This is very, very important. Grade 2 is when it goes into cavernous sinus, the lateral dural wall is intact. It encases the internal carotid artery. Diaphragm is intact, lateral dural wall is intact. Has to be understood if you have to do this. It can be stretched, lateral wall can be stretched, but cannot be transgressed. They respect the mother dura. Now you see this beautiful slide, intracavernous extension, lateral wall is intact. Beautiful slide. Dural roof is elevated, dura. So it is diaphragm, this is dura of the roof of cavernous sinus. Dura of the roof of cavernous sinus. Dura of diaphragm, dura of roof of cavernous sinus. You see very clearly seen diaphragm, dural roof of the cavernous sinus. If you have to do these tumors, this anatomy has to be understood. Dural roof, diaphragm, dural roof of cavernous sinus. Grade 4 tumors are when it transgresses the mother dura, when it behaves irrationally and irrelevantly or aggressively. I call these people who do not respect the mother as aggressive children or aggressive tumors. So this is my grading scale. The dura is intact, lateral wall is intact, dural roof is elevated, and when the arteries of circle of Willis is elevated, that is grade 4. These are malignant tumors, rest of them are benign. This diaphragm celli anatomy, in my estimation, has completely changed the face of pituitary tumor surgery. This concept was not there earlier in the literature. You see this tumor, diaphragm is elevated, you break into the tumor, and you can very quickly resect this tumor and the diaphragm will come into picture. I did this in 1997. So like uterus, the baby will be pushed by the uterus. Similarly, the diaphragm will push the tumor down. You have to understand this concept. You see, this is a pregnant tumor. You remove the baby first and the mother itself will come down and subject herself to you. This is post-operative in 2000, 20 years ago. This tumor, quite straightforward, if you know one concept, that the diaphragm is intact. If you have this concept, this subfrontal extension, no need for transcranial surgery. In 15 minutes, you can remove this tumor. No need to remove the tuberculum celli or planum spinalis, just anterior wall. Demolish the tumor. The dura will be like this and can be removed. No matter how extensively it goes, you can remove this tumor from the nose. Whether you use endoscope or whether you use micro, that is very minuscule of a problem. You see this tumor, 20 years ago, I removed this tumor by the concept that the diaphragm is intact and this is post-operative. And in a very quick time, this is another tumor I operated. You see this dura is intact and this is post-operative image. Cavernous sinus is a different issue. When to remove, when not to remove, and how to remove is an issue, but one must understand the dural anatomy of this tumor. The fact that dura is elevated has to be understood. If you have this concept, you can remove this and you can go from the cavernous, from the sella into the cavernous sinus and go into the under the roof of cavernous sinus dura. This anatomy is most beautiful anatomy, and how to do and what to do these kind of tumor is a different issue. Now I will show you another benign tumor, trigeminal neurinoma. In 2003, I published 73 cases of trigeminal neurinoma. Now my series is nearing 300 cases. First time I published that trigeminal neurinomas arise from the Meckel scale. They arise and they remain within the dura of the lateral wall of cavernous sinus. In the year 2003, I said that this part of the tumor is subarachnoid. But this concept later changed because later I published that even this part of the tumor can be interdural in several cases. So you work within the dura here and also work within the dura or work under the arachnoid, respect the mother dura, respect the mother arachnoid, and you can do fantastic and quick job. In 1995, I described interdural approach. So during those times, these tumors were very difficult to operate. So I did this kind of exposure, just opened the Michael's foramen ovale, worked within the dura and removed these tumors. In 1994, I did this. In 1995, I removed this tumor, working within the dura without doing any craniotomy. Even the tumor which extended into the posterior cranial fossa, I did it without craniotomy, just doing the lateral dural wall of foramen ovale and working within these pictures were published in my article in 1995. This is another picture from the same article without opening the skull. So this tumor remains within the dura. If you have this anatomy, this is an easy tumor to remove, and you can remove in very quick time. And many of these posterior fossa component is also within the dura. In 1991, I did this in 2 stages. You see, though at that time, 30 years ago, these tumors were removed in 2 stages. So this is posterior fossa, then middle fossa, and this is 2 stage. But when we, as skull-based surgery advanced, contributions from various people like Leonard Mallis, Hakuba, and Lullingham Shaker, and these kind of people who completely revolutionized this field. So this is roof of I used to do this kind of basal work at that time, but as I advanced further in my experience, I do just this little bit of exposure, little bit of craniotomy, subtemporal, basal subtemporal exposure for many of these tumors, and 1-stage exposure. Open the dura, work within the cranial nerves, and then demolish the tumor. We young neurosurgeons have to learn, not young, everybody has to learn how to demolish these tumors, and you can do a fantastic job and a quick job. If you do not know this anatomy of dura, you may do proximal exposure, distal exposure, and you will never be able to reach the area. Quick exposure, radical resection, complete cure, and for the first time in the literature, we describe that you can improve the sensation of the 5th nerve following these tumor resection. Even when the tumor goes extracranially, they are within the dura. This anatomy you have to know. And when you know this anatomy, you can do transcranial or extracranial, and there is no cranial nerve or no artery within the tumor. This anatomy is very clearly has to be understood. Like trigeminal neurinoma, C2 neurinoma is very parallel. Vertebral artery here, carotid here, cavernous sinus here, huge venous plexus. This tumor also remains within the dura. So this was my understanding several years ago, that this part is intradural and this is interdural, like trigeminal neurinoma. I published this in 2008, 60 cases where I said this is intradural. In 2018, I said that even this is interdural. Work within the dura and you can do a very rapid job and quick resection like trigeminal neurinoma. C2 neurinomas can be removed beautifully by one premise, that dura remains intact. This is third nerve tumor. Third nerve tumor is interdural within the confines of dura. No matter how dangerous it looks, how difficult it looks, if you know that there is a dura, it is not the capsule of the tumor. You don't have to remove the dura. Work within the tumor, learn the art of demolishing the tumor, and you can save the third nerve function or improve the third nerve function if you know that these tumors are surrounded by dura. You see, they arise from the oculomotor cistern, open up the dura and elevate the dura, and surrounded by the dura. This is not capsule. And this is a beautiful anatomy that you have to understand. There is a dura around the third nerve. And if you know this anatomy, you can improve the function. Sixth nerve neurinoma is intracavernous sinus. I am still learning on these tumors, and I will come back to you very soon on these tumors. Seventh nerve tumor arises from the geniculate ganglion. Beautiful anatomy. You must know this anatomy. Geniculate ganglion, and they remain within the dura. If you know this anatomy, that the whole thing is under the dura, you come from lateral, open the dura, and you can improve the seventh nerve function. Nobody in the world has described this. And there is a possibility, interdural approach, and you can have a quick exposure, radical resection, and a beautiful resection. So you must remember this, that these tumors are skull-based tumors, difficult tumors, but philosophical. They respect the mother dura. Similarly, lower cranial nerve tumor, they are interdural. Beautiful. You have to know this anatomy. You see, this tumor is completely within the dura. Work within the dura, work within the dura. Don't go outside the dura. You can improve the function of the lower cranial nerves. Even when the tumor goes outside, there is a well-defined dural anatomy around. And this anatomy is absolutely critical if you want to improve the function. If you remove the dura, considering that it is capsule, you have demolished the patient. Now I want to show you chordomas. Chordomas are extradural tumors. They completely dura will remain.
Just to let you know, Atul, 2 minutes.
Okay. But you gave me 20 minutes or you gave me less, Imad?
I gave you 22 minutes. So
I have 2 minutes left. Okay, you stop me, because I cannot stop, you know me. So these tumors are extradural. Dura is respected. Cavernous carotid is displaced anteriorly by the tumor. Very beautiful. Cavernous sinus is displaced superiorly by tumor. So this anatomy, if you know, you can do wonders with this tumor by coming from lateral and removing dura will be intact here. So this tumor, I published this article in 1995. This artery is displaced anteriorly. The whole thing is without any artery. Work within the tumor and you can do a beautiful resection. So I described this approach, middle fossa subgastrin ganglion approach to these kind of tumors. And this tumor, you see the carotid artery is anterior. You must know that the dura is present here. Work within the dura, and you can do a quick job and a very beautiful job for these tumors. Recently, I described supracerebellar approach for clival chordoma. This tumor, of course, you can come from nose, you can come from lateral, but I removed this tumor from here. Why I removed from here? Because the sixth nerve comes under my control and I can save the sixth nerve function and beautifully resect this tumor. Both sixth nerve under my control, hold proximal, and then demolish these tumors. And this is the post-operative resection. So I don't want to go too much on cavernous sinus meningioma, but I want to show you that these tumors, cavernous meningioma has a different world of cavernous meningioma, but unfortunately due to time, I cannot show you much. But many of these pictoclival tumors, I described the supracerebellar approach for the first time in the literature, and it has become very popular approach in the world of pictoclival tumor surgery. And I hope, and I wish, and I am sure that you know of this approach because Vlad is very familiar, Dr. Vladimir.
Right.
And so thank you very much.
This is his baby. He likes it. Thank you very much, Atul, for the wonderful presentation.
Thank you, Imad. And I hope young neurosurgeons in the audience will try to understand the anatomy of the region. That is one. Second thing is anatomy of the tumor, which is number 2, and the more important. And each tumor has its original discrete identity that has to be loved, respected, and then the operation has to be conducted. Thank you very much, Imad.
Thank you, Atul. You are always a favorite invitee to the faculty of this webinar and to share your vast experience. I'd like to give the moderation over to my colleague and friend, Professor Giovanni Perci from Milano. He will conduct the moderation of the next session. Go ahead, Giovanni. Unmute yourself. Giovanni, unmute yourself.
Then let me.
Okay, thank you. It's a great pleasure to call to the podium, to virtual podium, Sebastian Frohlich, that will give us a lecture on the neuroanatomy of anterior petrosal with approach and indication. Sebastian, to you.
Thank you very much. Happy to see you all. Fantastic webinar. As usual, fantastic organization. Thank you, Imad. I know that you are you are the one behind all this. So thank you very much.
No, this is the team. Thank you.
I share my screen. Hold on a second. Yes, here it is. You can see it. Not yet. Now. Yes?
Yes, we will see it.
Yes. Perfect. So, subject of my talk is anterior petrosal approach, focusing on the anatomy, focusing on the technical steps of this approach. So, as you all know, the anterior petrosal approach is a middle fossa approach. It's an extradural approach below the temporal lobe. Being extradural, you need to expose the petrous bone from above, and you drill through the petrous bone to have access to the posterior fossa dura. So looking at this picture, you can understand that it's a great approach to reach petrous apex extradural lesions, for example. There is not so many types of lesion like this. Chondrosarcoma is a good example, but it's also a great approach to access the posterior fossa from an anterolateral angle. This is a drawing from one of my previous fellow, Kentaro Watanabe, showing this line of sight going through the petrous apex below Meckel's cave and a little bit anterior to the internal auditory canal between two sinuses, superior petrolized sinus, inferior petrolized sinus. There is a kind of mistake in this drawing because it gives you the impression that the superior petrolized sinus is big and the inferior is small. It's exactly reverse. The superior petrolized sinus, in fact, is not so big in this area, but the inferior petrolized sinus can be an issue during this type of surgery. This is another cartoon from Kentaro showing that it's an extradural approach. You have to peel the dura from the temporal fossa floor. You expose Kawase triangle, find the landmarks, and you start to drill the petrous apex just like you would drill an anterior clinoid through a frontotemporal approach to expose the posterior fossa dura. You open it and you have a great access to the exit zone of 5. So what is the advantages, in my opinion, for this approach? First, you don't cross the nerve compared to the retrosig, for example, to reach petroclival lesions. It's an anterior line of sight. So for brainstem cavernoma, some of them, I really feel that it has some advantage to really get to the deep part of the cavernoma, which is sometimes close to the floor of the fourth ventricle. It's an extradural approach. So if you are treating a meningioma, you reach the dura first, so you can devascularize it first prior tumor resection. When there is a lot of feeders, when it's a bloody tumor, it definitely can be an advantage. It exposes Meckel's cave, so it's nice for tumor into Meckel's cave. It exposes the mid-clivus, and I don't see the end of my slide. Oh, yeah. And it gives you a contralateral visualization and an anterior view of the brainstem and its perforators also, and branches. Disadvantage, it's a kind of bloody approach when you peel the dura from the temporal fossa floor, because there is venous channels, venous plexuses going through foramen ovale that are usually bleeding. It's quite easy to control, raising the thorax to reduce venous pressure, using flow seal, which make it much easier since we have it, and tamponade and waiting a little bit, and usually it stops most of this venous bleeding. You have to be careful because sometimes some important vein drain in this area through pterygoid plexus, through foramen ovale. It can happen. So taking a look on the venogram, especially on the left side, is important. Brain retraction is important and can be a source of complication because you have to elevate the temporal lobe a little bit. So playing with intracranial pressure is extremely important, raising the head, using mannitol, draining CSF. This is a fantastic picture from Albert Rotten showing this temporal fossa floor from above. You have here trigeminal nerve with the third division. Here you have carotid artery, GSPN, foramen spinosum, and here the superior petrolized sinus. We can see here air cells above the middle ear. This is after drilling the bone to show you the anatomy behind it. You have here the internal auditory canal, superior semicircular canal, greater petrosal nerve, carotid artery. The cochlea is hidden below geniculate ganglion, below the junction between geniculate and GSPN. So the cochlea is always deeper than what we think. It's a fear that we have with this approach at the beginning, but in fact, the risk of getting into the cochlea is not so significant because it's deeper than what we think. What are the indications for this approach? Petrous apex tumor, chondrosarcoma, chordoma, cholesterol granuloma, no more in my practice because now I do it endoscopically on some bone tumors. It's an approach for Meckel's cave tumor, trigeminal schwannomas. We had some great example from Professor Gold just before. Petrous apex meningioma, sometimes when it's going quite deep into the brainstem, pushing the brainstem posteriorly, it can be interesting to have a more anterior line of sight. It's part of the approach for some petroclival meningioma, sometimes alone when the tumor is not too low, but sometimes combined with posterior petrosal. And it's a nice approach, in my opinion, for some brainstem cavernoma. It's very important to look at your preoperative workup carefully because most of the issues that you can have during anterior petrosal approach, you can find the solution, you can prepare yourself for difficulties just by looking the CT, the MRI very carefully. This anatomy is hidden below the bone, but CT give us the opportunity to see it before. So shape of the temporal floor, arcuate eminence, relationship with the superior semicircular canal, how pneumatized is the petrous apex, is there air cells in the zygoma? If you cut the zygoma, you may open it. If you don't figure it out, you can have a leak post-op just because you forgot to put bone wax in this area. It's important to know if there is bone over the ICA. Sometimes it's very rare. You may have superior semicircular dehiscence. If you peel the dura from it, you can create some hearing loss. And most important is to look if there is some bone over geniculate ganglion, because again, peeling the dura, you can injure geniculate because it's not covered by bone. So to me, this is the best neuronavigation system ever. It's quite cheap. It's just a CT scan. If you look at this pneumatization on the petrous apex, it's a roadmap. You get into these big air cells medial, then you move to the one more lateral, then you move towards the cochlea. You can navigate into those air cells. So very important to look at this before. It's the same if there is no air cells, but cancellous bone. You have this cortical bone that is your limit here, and this is cancellous bone. Sometimes it's very soft. And you move laterally, when you start to see hard bone again, it means that you are not so far from the cochlea. Here it's show you the depth of the cochlea. This is an information that I always look at before doing the case. How deep is the cochlea? Sometimes it's 1-2 millimeters, sometimes it's 5. And it's important to know because it defines the risk of injury to the cochlea. This is an example where you see geniculate, and you see the cochlea is very much below. And your line of sight with retraction of the temporal dura, in fact, never cross the cochlea. So this situation is quite safe. Here is a case of dehiscence of the superior canal. What is the position? Supine or lateral position. I prefer supine position with elevation of the shoulder. Quite a lot of rotation. That's why you need to elevate the shoulder. 80 degrees, I think is nice. Question mark incision. I monitor 7 always. You may monitor other cranial nerve depending on the situation. MEP, SSCP depending on the pathology. I'm not using lumbar drain anymore because the CSF for the extradural approach, I think, is a great protection for the brain. If you remove CSF before elevating the dura, when you manipulate the dura, it's the same as manipulating the brain. It gave you the false impression that the brain is protected, but punching the dura is punching the brain, and there is no CSF protecting the brain. So rotation is important, but it depends on the pathology. This is a case where there is definitely too much rotation. And if you want to adjust, you will have to bend your neck to look at the tumor. So you have to adjust the rotation to the direction you really want to reach the lesion. This is extremely important. It starts with soft tissue dissection. I start with interfacial. I don't remove most of the time the zygoma. If I really need to go up sometimes, but it's not so often. Retrograde dissection of temporalis muscle, and the bone flap needs to be anterior enough. This is a video showing you the first step of the surgery. Question mark incision. You elevate the skin flap, and nothing special with it. And then you need to mobilize the temporalis muscle. I don't like to cut the fibers of the temporalis muscle too much. You need to expose here the root of the zygoma. It's very important. If the root of the zygoma is not exposed, you may not be anterior enough. This is why I do also interfacial dissection to retract the skin more anteriorly. And here I incise the muscle just above the zygomatic root and the retrograde elevation of the temporalis muscle to keep this periostal layer deep intact, to keep the muscle intact, to keep vessel and nerve. It's like the pterional approach, but it's going a little bit more posterior above the root of the zygoma. Once you have done this, you do the craniotomy, nothing special about it. Resection of the zygoma, either a small cut on the zygoma or this chicken bone zygomatic resection that give you the advantage of being able to retract the temporalis muscle more anterior. It's nice when it's more a cavernous sinus tumor, for example. Then you need to elevate the dura from the temporal fossa floor. You elevate going from back to front. Gentle traction of the dura. You have to be careful with geniculate ganglion if it's not covered, and you progressively identify your landmark. Subarcuate eminence posteriorly, foramen spinosum with middle meningeal coming out, and a little bit more anterior and medial foramen ovale. Once you have this, you cut middle meningeal, and you can peel the dura a little bit more medially to find GSPN. How to find GSPN on geniculate? Stimulation is mandatory. You need to stimulate at quite high power at the beginning, and the closer you get from the GSPN, then you lower the stimulation to find the threshold. This is the landmark, subarcuate eminence here, foramen spinosum with middle meningeal. It's important to be aware that arcuate eminence do not always correspond to superior semicircular canal below it. This can be envisioned and prepared looking at the CT scan. Section of the middle meningeal, you coagulate and cut. I leave usually a few millimeters of middle meningeal, and then you find GSPN. GSPN is usually embedded into a little bit of periostom or connective tissue, so it's not always clear. And you have to be aware that there is an angle between GSPN and carotid. GSPN is not exactly parallel to carotid. You need to avoid also to avulse GSPN from geniculate ganglion. This is why you need to elevate the dura from back to front, posterior to anterior. But if you're too strong, elevating the dura from back to front, you can also tract GSPN away from geniculate ganglion. And I had one case where I had some response of the fascial nerve doing this, and the patient had a transient fascial palsy post-op. Looking at this temporal fossa floor, where is GSPN? Not so easy to say. Is it here? Is it here? Is it here or here? Only stimulation can really conclude and tell you that GSPN in fact is here. So once you have find GSPN, you need to elevate a little bit more the dura, and you have to separate the dura from the V3. Because if you don't do that, and if you tract on the dura, you will also tract on V3. So you need to peel the temporal fossa dura away from V3, doing a small incision of the periostom along foramen ovale. It's the same principle of peeling of the lateral wall of the cavernous sinus using Akupa or Kawase technique. This is a cartoon to show you that. In red, it's periostom. In green, it's temporal fossa dura. You elevate the dura from the temporal fossa floor. You drill a little bit of bone along foramen valley. You cut this bridge of periostom and you keep going with the elevation of the temporal fossa dura from V3. And it gives you additional exposure of the temporal fossa floor more medially. It gives you the ability to reach the petrous ridge more medially without too strong retraction. Retraction is an important issue. How to retract? At the beginning, I was using a retractor like this. I stuck the retractor behind the petrous ridge. I have to say that now I am not using retractor anymore. I am using stitches on the dura and I use dynamic retraction. I think it's better, it's safer for the brain. And in fact, you don't really need those retractors. Just retracting the dura with your suction. I like to feel this pulsation of the brain behind my suction. For this, you may need lumbar drain. As I said, I'm not using it anymore. You need to evacuate CSF with a small incision at the beginning of convexity, like this. Progressively, CSF goes out, drops after drops. You need good anesthesiologist, and you need to be careful with the position head up. So this is what we expose. The Kawase triangle, limited by V3, limited by GSPN, limited by subarcuate eminence and petrous apex. 3 areas of drilling: premeatal corridor, meatal above internal, auditory canal, and postmeatal triangle. And this is defined by landmarks, GSPN, and you have the cochlea below the bone, and you have the superior semicircular canal, not always completely below subarcuate eminence. There is an angle between GSPN and internal auditory canal, 60 degrees, and you have a vertical line between external auditory canal and internal auditory canal, but this depends on the rotation, obviously, so it's not very reliable. So how to drill? I start to drill usually very medial, a little bit lateral to Meckel's cave. And then progressively I move forwards. Once I am in the cancellous bone, I move forwards towards the carotid. You don't need to completely expose the carotid. Depends on how low you need to go. The lower you need to go, the more lateral you need to drill. Then I move back to the cortical bone of the posterior fossa, and then I move forward towards the internal auditory canal. It's very important to understand that between 3 and 4, there is not an acute angle. It's very smooth transition between the posterior surface of the petrous apex and the anterior surface of the internal auditory canal. And then I drill more towards the cochlea. This is what usually beginners are afraid of. But again, looking at the CT scan preoperatively, the depth of the cochlea gives you additional information to do that safely. And if needed, you may drill behind internal auditory canal, postmeatal triangle. It's a little bit tricky area to drill because you have superior semicircular canal just in front. And finally, you need to drill the petrous apex, the true petrous apex. The true petrous apex, in fact, is below Meckel's cave. And for petroclival meningioma, for example, it's extremely important to drill this area because this really will allow you to coagulate the medial clival artery, for example. And finally, if you want to get closer from the cochlea, really to have a lower exposure into the CP angle, into the prepontine cistern, it's a little bit tricky. I personally follow the labyrinthine portion of the facial nerve, and then it gives me the position of the cochlea. This is how I get very close to the cochlea. But again, this is rarely necessary. Postmeatal drilling, why do you need it? You need it maybe to go more laterally and to have exposure of the middle cerebellar peduncle, and it gives you also a better exposure of the cisternal segment of 7 and 8. Then you need to open the dura. Open the dura, you can make an incision on the temporal dura parallel to the superior pectoral sinus, incision on the posterior fossa dura of the petrous apex, and then you have to cut superior pectoral sinus and to cut the tentorium. It's better to cut superior pectoral sinus as anterior as possible because you may keep the drainage of the superior petrosal vein. It's not always possible. Depends on the anatomy, depends on the pathology. Usually, sometimes in petroclival meningioma, it's already occluded, but this, again, you can look at it on the MRI, MRV before or angio. Cutting the tentorium, neuronavigation is nice here because it's not always easy to understand the direction, where to go. If you go too anteriorly, you can cut forward. If you go too posteriorly, you may not find the free edge because you will cut behind. And at the end, this is the exposure. You have the exit zone of 5, and you understand here that if you want to open Meckel's cave, you just have to keep incising here, making an incision here along V3 to open Meckel's cave like a book. What is the morbidity, potential morbidity of the approach? Temporal lobe, if you're not careful enough with your retractor, or even with your dynamic suction, thinking that behind the dura there is nothing, you may create contusion of the temporal lobe. Seizure, I had 2 cases of seizure during the surgery when I was using lumbar drain, and this is why I stopped using it. It was not injury of the brain on the post-op MRI, but I think the irritation of the brain with movement of my suction on the dura directly transmitted to the brain because there was no CSF anymore, created those seizures. Temporalis muscle atrophy, TMG disorder, CSF leak, facial nerve palsy with injury to the geniculate, hearing loss if you open semicircular canal. Show you 2 or 3 cases. This is a cavernoma of the brainstem. I like to use anterior petrosal because this cavernoma is going quite far back posteriorly. This is a video of it, incision like before. I'm gonna go faster. Here is the interfacial dissection, again, to retract the skin flap more anteriorly. I expose here the root of the zygoma. It's very important because it gives you anterior exposure. If you don't expose it, you may be too posterior compared to your target of the anterior petrous bone. Here is retrograde dissection of the temporalis muscle. Here is above the zygoma, you really need to peel the muscle from this gutter formed by the zygomatic root. Here, in this case, I cut the zygoma. As you can see, this allows you to retract the temporalis muscle lower and more anteriorly. This is here the bone flap. Closing air cells here on the root of the zygoma. Section here of the middle meningeal artery. I leave a little bit of artery distal. Here is elevating the dura from V3. Now elevating a little bit the dura from V3 and from Meckel's cave also. You can start to see the position here of GSPN. There is venous bleeding, but you can control it again quite easily with Surgiflow or Flow Seal. It was a case where I was still using a retractor, but you know, anteriorly, I don't have one and I put stitches. I start the drilling medially and then move progressively laterally towards the carotid artery. Here back to the posterior aspect of the petrous bone and drilling more posteriorly towards the anterior aspect of the internal auditory canal. This is here above the internal auditory canal towards the posterior meatal corridor. A little bit of CSF, it's always helpful. Now is incision of the dura, section here of the superior pectoral sinus, incision here of the sinus after putting 2 stitches, connecting to the incision of the posterior fossa dura. And then cutting the tentorium towards the free edge. Using the navigation here is nice. And I start to see here the root of 5. Root of 5, and I will do my incision for the cavernoma, I believe in this case, a little bit above, small incision on the brainstem to get into the cavernoma, resection of the cavernoma. Okay. That's, I will, this was a case of petroclival meningioma, but it was not going very low. So I did an anterior petrosal approach. It was also nice because a lot of tumor were into the petrous apex. The only thing I didn't want it to do in this case is to open sphenoid sinus. So I left a piece of tumor here because I didn't want it to enter sphenoid sinus and with a risk of leakage. I skipped the video, but it was a perfect case for an anterior petrosal approach. This was a nice case of chordoma. Chordoma quite lateral. This patient had a transient 6. I didn't want it to go endoscopic because it was purely cisternal. And also I was afraid of injury of 6 with an endoscopic endonasal approach. So here I did anterior petrosal approach, and then I used the endoscope for the lowest part of the tumor because it was going quite low, below the internal auditory canal. And if you read textbook and articles, it says that below internal auditory canal, it's tough to reach. Yes, it is, but it's without using the endoscope. With the endoscope, you can look down below internal auditory canal and have control of the tumor. If it's a little bit soft, like chordoma, in fact, it's very nice. So here is looking with the endoscope. You can see the 6th nerve. This was the maximum, my inferior limit with the microscope, but putting the endoscope inside, I had a quite nice control of 6 that was quite adherent to the tumor, but careful elevation of 6. The patient had a 6 post-op, but he recovered after a few weeks. I don't think I would have had this kind of recovery going endonasally. I switched the endoscope to look at the clivus to remove the part of the tumor into the clivus because there was still a little bit of infiltration of the clivus. Chordoma comes from the clivus. What else? You know that anterior petrosal can be combined to combine posterior petrosal to have a combined petrosectomy. This is a case of combined petrosal here that I did for a chordoma case that was going quite widely into the subarachnoid space with with a part into the cavernous sinus. I did a 2-stage surgery. 1 stage for everything that was extradural, and another stage for what was intradural. So here is a video of it. So this is the exposure. Do you hear me? Yes?
Yes.
Okay.
Yes, yes.
So this is the exposure, classic exposure of a combined petrosal. I have a specific incision for combined petrosal approach. Here is a bone flap. It's a kind of mini combine with cosmetic mastoidectomy here. So mastoidectomy, posterior petrosal approach, I go fast on this. And once you have done that, you combine it with the anterior petrosectomy. Here I have a little bit more posterior line of sight compared to the pure anterior petrosal, drilling here the petrous apex, exposing the posterior fossa dura, drilling above the internal auditory canal. This is the final exposure. No need for retraction here. Incision of the dura is a little bit different here because you need to mobilize the transverse sinus completely. This is what gives you, in fact, the corridor of exposure. Okay, I think I stop here because I am running a little bit late. So in my opinion, anterior petrosal approach is extremely important approach in skull-based surgery. It's true that if you're not a skull-based surgeon, the opportunity to use this approach are not so much, but there is a lot of indication, as I told you at the beginning of my presentation. Knowledge of the anatomy is absolutely necessary, and I strongly believe that this is typically an approach for which you need some training in the lab. Again, like any skull-based approach, the final goal of it is to protect the brain, not to drill the bone. You drill the bone in order to protect the brain. So it's an approach where you constantly need to keep in mind that you are below the temporal lobe and the structure you want to preserve is the temporal lobe. Thank you very much.
Thank you, Sebastian. Wonderful presentation. There is no, I don't see any question on the chat. So
sorry, there is one question by Alessandro Melatinini, I think from Italy. He is asking about the petrosal sinus injury during the exposure. What do you do? I think you mentioned it, but if you just summarize it in one line or two line, Sebastian.
For the petrosal, superior petrolized sinus or inferior petrolized sinus?
Inferior.
Inferior, I try to avoid it because again, it can bleed significantly. If it's a petroclival meningitis, not so much of an issue, but if it's a cavernoma, yes, it can bleed significantly. I try to use flow seal, but not too much because you can inject a lot of flow seal and have issue with all this flow seal into the venous circulation. So it's a little bit of flow seal, Surgicel, and tamponade.
Thank you.
Hi, Giovanni, can I ask a question?
Yes, please.
Sebastian, thank you. Great talk as always. And I really enjoyed the bit about planning the whole operation through your CT scan. Can I just ask, because you combine endoscopic and open approaches a lot like we do, and do you think the location even in soft tumors in relation to the carotid artery really matters? So the tumor is behind the paraclival carotid or lateral to the horizontal carotid, would you favor an open approach, or do you, even in soft tumors like chordomas and chondrosarcomas, a bit of drilling is required, would you go endoscopically? So the relationship of tumor to the carotid artery in the petrous bone.
It's not so often now that for petrous apex tumor, I go with an open approach, in fact. Petrous apex tumor like chondrosarcoma, for the vast majority of it, I go endoscopic endonasal. And with angle instruments, angle endoscope, in fact, you can go quite far up to the internal auditory canal. It's just a question of having the good instrumentation. My indication for petrous bone tumors going open, it's when the tumor is going more laterally than the internal auditory canal. And there is some chondrosarcomas that are quite lateral and for which purely endonasal is not good enough because it's going too far laterally.
Thank you.
Ahmad, may I ask?
There is a question from Jack. Yeah, go ahead.
Sebastian, as always, masterful presentation, but just a small detail of nomenclature. You've been calling it subarcuate eminence. You mean arcuate eminence, don't you? There is the subarcuate. I don't want the young people to confuse subarcuate fossa, obviously with but you've been calling
Absolutely.
it. You agree with? Okay. So you have to correct all those beautiful slides that you have with the correct.
I thought you would mention the tubercle of Prince Otto.
That's right. Well, next time I'll explain it to you again.
Okay. Any other question?
Yes, I have a question. Yes, thank you. Thanks, Sebastian. It was a very nice presentation. Can you guys hear me?
Yes.
Great. So I have just a comment. I think the first thing is that I know that you mentioned using navigation. I think that using neuronavigation to drill the temporal bone is probably one of the best application of neuronavigation because the temporal bone, the bone is fixed, does not move. So that certainly may help, especially when you are close to the cochlea and everything else. And as everybody knows, even a change of 2-3 degrees in the angle of approach compared to the way the CAT scan was done, that makes a huge difference. So usually when I do this approach, although of course I rely on anatomical landmark, but I supplement them with neuronavigation and I use the focal point of the microscope as the virtual pointer. And then the other thing that I do a little bit different is that as the intrapetrous carotid artery is of course a very important structure, I try to visualize it quite early during, during the approach. And I usually, the intrapetrous, at least the horizontal portion of the intrapetrous carotid artery, it's not covered by very thick bone. Sometimes there is no bone, and sometimes there is a very thin lamellar, bone. And I drill all the way, posteriorly until I see the horizontal portion disappearing and going into the vertical portion. And then I can, of course, using the neuronavigation, then I am confident that I can drill everything that is medial to that. Everything of the petrous upper is medial to that, because the cochlea usually it's anterior to that. So those were just two small comments.
It's a very good point. The only thing I would say about exposing the carotid artery is that personally I don't do it very often because I am always afraid to sacrifice GSPN. And for example, if you have a tumor where you will deal with trigeminal nerve, like a trigeminal schwannoma, and an addition of V1 injuries that you can have with a trigeminal schwannoma on the GSPN injury can be bad for the eye. I try to preserve GSPN, but I completely agree with what you said, that having an idea on sometimes taking advantage of the fact that there is no bone over the ICA is important to visualize it. Absolutely.
Okay, thank you. There is some other comment or question? If not, thank you, Sebastian. And we move to the next speaker, Miguel Larraz from Spain. Is here? Yes, I saw him before.
Okay, good morning and good afternoon and maybe good night in the East. Can you see me and hear me?
Yes.
Yes, we hear you and we saw your slide. And I don't know if everybody's, but I saw the slide.
Thank you very much, Dr. Brody, as moderator, and thank you to the leadership of this wonderful WFNS Neuroanatomy committee. Thank you for the invitation. I'm going to speak about Petrus apex, neuroanatomy and surgical approaches. I think that I have little to add to the wonderful presentation of Sebastian Fröhlich and also the wonderful cases of Atul Goel. But anyway, I will just go over the anatomy and some cases. Just top left, you can see in this slide from Vinko Dolen, you can see the Petrus bone, the Petrus apex itself, the anterior Petrus apex, because we have an anterior Petrus apex and posterior one that is just behind the internal auditory canal. And we also can see the relevant neuroanatomy, neurovascular structures, B3, B2. This is the Gessiran ganglion, superior petrosal sinus, Petrus carotid artery, and GSPN. Important to mention that very frequently, and as in this case, Petrus carotid artery can have just a very thin layer, only just covering this Petrus segment, so we can provoke some disaster if we are not aware of that. Just top right, we can see the trigeminal ganglion, the division, the relationship with the real internal, with the real cavernous sinus, and also the Petrus apex. In this wonderful slide, I'd like to thank Pablo Gonzalez and his team of the 3D Neuroanatomy Lab in Alicante, Spain, for giving me this wonderful anatomical slide. We can see the way we could get inside the Petrus, we can get inside the posterior fossa, and I think that Sebastian Fröhlich showed a very nice example of how to get inside the brainstem through the Petrus apex. And now we can see this more complex neuroanatomical view of the Petrus carotid artery, inferior petrosal sinus. After drilling, we can see the dura of the posterior fossa. we can see the sometimes difficult relationship with the trigeminal nerve. This is the segment, the intracisternal segment, content of the internal auditory canal, and this is the fourth nerve, the sixth nerve. In summary, we are not only talking about the petrous apex, the petrous bone, but also about the petrous apex area that is, to my knowledge, very complex. We can start with the role of microsurgery, and I think that the step has been mentioned. We have to do a zygomatic osteotomy or cranio-orbitozygomatic osteotomy. We usually do not a cranio-orbitozygomatic approach, just in case a zygomatic osteotomy, because the only usefulness is the possibility to reflect downward the temporal muscle, just diminishing the retraction of the temporal lobe. We have to identify laterally the middle meningeal artery and the third division of trigeminal nerve, the peeling of the trigeminal nerve complex, that is some incorporation to that kind of surgical skull-based approaches coming from the 80s. And after this peeling, and at the same time, we have to preserve the GSPN and also, of course, identify and preserve the petrous carotid artery. We can go to the first division of the petrous apex region, the first lesions that are particularly restricted to the petrous bone. The typical example is cholesterol granuloma. We also have chondrosarcoma. We also have primary cholesteatoma in this area. We can make a simple incision. We can do just this limited zygomatic osteotomy in case you have a very bulgy temporal muscle that is going to make difficult your retraction of the temporal bone. You can do a very small craniotomy, and this is the way you can identify the third division, second division, trigeminal ganglion. This is dura mater. We have just started to see the cholesterol granuloma with its typical appearance. This is petrous carotid artery, and this is GSPN that has, as mentioned before by Sebastian, a variable course, and sometimes is difficult to be identified, mainly in all patients with very sticky dura to the bone. And this is the way we can make the exposition and very easy removal. This is a cholesterol granuloma we operated on more than 25 years ago. You can see how CT scan is leading you to the relevant anatomy, and you cannot need neuronavigation for that kind of very easy to identify lesion. This is the way we used more than 25 years ago to identify the lesion, identify petrous carotid artery, and for complete resection of the lesion and full exposure of this is the first loop of carotid artery, petrous segment, second loop right before getting inside cavernous sinus. The only way of just having this view is cutting the third division of the trigeminal nerve. We used to do that more than 25 years ago, and after that we used to suture with the hope of having some good recovery. In any way, this is the resection, the view of the anatomical field, surgical field after resection. But for those that think that cholesterol granuloma is a very indolent lesion, see what happened with this patient. He was lost for follow-up, and the patient came back last time to Malaga, because this operation was done in Granada, my former institution. And you can see this huge lesion as view after CP angle approach. These are lower cranial nerves. So be very much aware of the possibility of recurrency in cholesterol granuloma. Chondrosarcoma is another typical lesion. You can see the CT scan you can see the MRI and the way you can do this transpitous resection the way we have shown before and following these surgical steps. This is another chondrosarcoma. You can see the moment the lesion is breaking the dura mater and getting inside CP angle, and this is after transpitous resection, removal of the lesion. Second group of tumors and lesions are located at the extradural interdural space. This is basically lesion related to the trigeminal ganglion. You can see this patient, this is a psychiatrist from Malaga who was complaining of intermittent headache, facial pain, and diplopia. You can see the lesion, you can see the both layers and inside trigeminal ganglion with this appearance. And this is the very easy way you can do some extradural approach. I think that this slide is showing the relevant anatomy for the youngest colleagues participating in this webinar. You can see the trigeminal nerve, you can see the trigeminal ganglion that is inside Meckel's cave. You can see porus trigeminalis, that is the opening where the trigeminal nerve is getting inside Meckel's cave and just convert into trigeminal ganglion. And trigeminal cister, that is variable according to anatomical factors, maybe absence or maybe hue. Trigeminal cister is expressing the CSF around the content and nervous content and inside Meckel's cave. So what we have to do is just some extradural approach, lifting dura mater and showing trigeminal nerve. But important, first of all, that we will find many different interpretation and many different publications, epidural, interdural, frontotemporal approach. We can show this very important paper published in 1995, infratemporal fossa interdural approach, that is one of the best, showing this interdural way of exposing and removing trigeminal neurinoma, and Atul Goel just showed us many examples. In any way, many different reference to one single concept, that is the extradural approach. But as Sebastian mentioned, we have to be very much afraid of the venous anatomy, quite variable at the temporal fossa. We have to see that we can have very prominent sphenobasal veins and infratemporal veins very frequently going around the third division of the trigeminal nerve, making this extradural approach very troublesome due to the bleeding. Now Flocil is easing many operations. Before that, it was in sometimes like a nightmare. You can see one of the anatomical slides from Pablo Gonzalez and his colleagues' anatomical lab, and the way the venous is around the third division. And you can see the sphenobasal and temporal veins, and you can imagine what happened at the extradural approach, a lot of bleeding. So in cases like that, you only have to open the dura, reflect very carefully after releasing CSF by means of spinal drainage or just opening cister, and that way you can show the lateral wall of the cavernous sinus, this bulgy image, and the very easy way you can remove the tumor, and in this occasion, fortunately, preserving the fibers of the trigeminal ganglion. So you can see another trigeminal neuroma, that is the dominant pathology when talking about interdural lesions at the lateral wall of cavernous sinus. And this is the easy way you can do if you have some problem. Extradurally, you can open dura and expose the lesion, as seen here. and the way you can, in this case again, fortunately preserve the second and third division of the trigeminal nerve. Not always possible, by the way, according to the case by case. Now we can go to the third category of lesion at the Petrus Apers area, Meckel's caves area, that are extradural and intradural lesion. I very much recommend to the youngest colleagues just to read this article published in 1999, Dr. Yoshida and Kawase. You can see them in Bali 10 years ago in a meeting. This is about trigeminal neurinoma extending into multiple fossa. You can see this very nice view that is showing the way maybe trigeminal neuronoma is the only lesion at the same time can be intradural and extradural, at the same time can be intracranial and extracranial. So according to the caprice, you can have many combinations, but in any way, it's important to mention that this sort of extradural or intradural approach is very useful to remove not only the Petrus Apers component, but also the component inside posterior fossa. Atuel Goel showed many examples. Sometimes you have to coagulate, or you need to clip according to the caliber of the superior petrosal sinus, and that way you can have some more easy way to make the removal of the lesion. This is the third nerve preserved. In that case, the fourth nerve was damaged during the approach, and very important, if you have to coagulate or clip the superior petrosal sinus and cutting tentorium, do not do it just closer, 1 centimeter closer to the clinoidal area. If you do that, you will for sure damage the fourth nerve. This is one of the rare instances we have done COC, cranio-orbito-zygomatic approach. This is a lesion of the trigeminal nerve that at the same time is extending into the orbit following the first division of the trigeminal nerve, the way we do not only the craniotomy, but also the COC craniotomy that, although describes in the 90s, must be avoided in many cases. This is the exception because it's a very time-consuming and morbidity-provoking approach, not necessary. This is the way we did that. We left some small remaining tumor here at the superior fissure, trying to preserve in as much as possible the function of the oculomotor nerves that already were damaged, by the way. And this is the way, in this particular case, and due to the histology, the lesion did recur in the way you can see here again, after this nice initial removal. You can see the recurrency of the lesion inside the orbit, inside posterior fossa, inside trigeminal ganglion. So we went again through transcranial approach with some slight modification. You can see the way you can get the whole tumor just following the way the tumor is leading, is providing for you. This is the vertebrobasilar artery, and this is the way, by means of combined endoscopy, we managed to remove the intraconal, the intraorbital content without COC, just using the endoscopic tool attached to the Kinevo microscope. This is the last slide after this operation, done maybe 1 year ago or something like that, with complete removal of the lesion, including the content of the orbit and, of course, the lateral aspect of cavernous sinus. This is another lesion recently operated on with rapid growing in an 18-year-old patient. You can see the lesion getting inside posterior fossa, and no matter how big the lesion is inside posterior fossa, this approach, anterior petrosal approach, following the tumor, you can get the whole lesion, including the content at the posterior fossa. You have to cut the tentorium a little bit, and you will have a very nice exposure of the lateral aspect of the brainstem and also the anterior aspect of the cerebellopontine region. This is a CT scan immediately after removal of the lesion. Histology, meningioma, clear cell meningioma that is going to be sent to radiotherapy. And this is another variation of the anterior petrosal approach and petrous apex, microsurgical petrous apex surgery. This is the extended middle fossa approach. Extended middle fossa approach is including the petrous apex drilling, as shown before by me and also Sebastian, but we have to add several dural osteotomies, coagulation, and section of the superior petrosal sinus, so that way you can get inside posterior fossa. This is one of the pictures of the publication in 1991 by Dr. Sekar and Dr. Sen. This is showing the way you can drill and get inside and have access to the petroclival and posterior fossa region. I have to mention that to my mind, there are few indications for this approach, that this is not an easy approach, that is, as always, very much relying on the anatomy and the size of the petrous apex that is quite variable. And there are three indications. Of course, one of them is meningioma. To my mind, I don't see many indications, although this approach was popularized by Professor Kawase with the main indication of meningioma. Second indication could be, as shown by Sebastian Freilich, anterolateral pontine tumor, typically cavernous angioma. This is a second indication. And third indication, and to my mind, the main indication, lesions that are growing at the same time at the petrous apex and also inside posterior fossa and petroclival region. So we can see chondrosarcoma, one of the typical examples for that. This is a young patient with multiple cranial nerve palsy. You can see the lesion displacing carotid artery, involving petrous apex, getting inside posterior fossa, distorting brainstem, and this is one of the good indication to my knowledge. This is.
You have 2 minutes.
Thank you. I will finish in 2 minutes. This is the fifth nerve, and this is the way you have to identify middle meningeal artery. In that case, middle meningeal artery and third division of trigeminal nerve were together. In one single unit, we have to identify and spare one from the other, as you can see here. Then you have to do the peeling of the trigeminal nerve. This is GSPN, this is middle meningeal artery, just cut, and we are just exposing the petrous apex. Until which extent you have to do the peeling and you have to expose the petrous apex. You have to do that until you are able to just go around with your dissector, as you can see here. Next step is just drilling the petrous bone. In that part of the operation, the petrous bone is completely normal. You will see how the drill is getting inside deeper, inside more easily. In this moment, this is the softer infiltrated bone. Move around. This is the petroclival dura. We just remove the tumor. Be very much aware of the possibility of damaging the cochlea and also the possibility of damaging the inferior petrosal sinus, whose anatomy is variable and may provoke some troublesome bleeding, as mentioned earlier. And we can see after drilling of the bone, this is dura mater, this is internal auditory canal dura mater, internal petrous carotid artery. And if you want, this is the third division of trigeminal nerve and trigeminal ganglion. If you want to see the real petroclival junction, you cannot do that unless you cut the fifth nerve or use endoscopy. And this is the way, with the aid of endoscopy, you can see some remaining tumor over here that can be drilled and removed. And this is, as mentioned earlier, you can see the way you have to do a parallel cut of the inferior surface of tentorium and dura. Okay, you can see the trigeminal ganglion. Let's move to the next one. We are coagulating. You can see the cisternal segment of the fifth nerve. You have to be very careful with when cutting tentorium and dura, because usually the fifth nerve is very close to the dura. And this is the way you are exposing the nerve protected by cottonoid. We have pushed away part of the bulgy tumor at the CP angle and petroclival region. We can drill that. And with the CUSA, you have to remove. And this is the final step. This is the fifth nerve. This is the anterolateral pontine region with some sticky tumor over there that is very carefully removed, trying to avoid damage to the brainstem. You can see not very good plane, so you have to be very careful in cases like that. And this is the pre and the postoperative MRI after removal of this chondrosarcoma to this approach. This is another case, a chordoma. I will move.
You have to go to the conclusion.
Yes, conclusion, thank you. Just some, you can see how you can make the choice for microsurgery or endoscopy, taking into account whether the lesion is a butting, a sphenoidal sinus, that makes the lesion very easy to be removed, whether or not intradural growing, how far and how posterior the lesion is, whether or not there is vascular encasement and extension to jugular foramen. You can see just below and right, bottom right, the fight between endoscopy and microsurgery. You don't have to do that. You have to be frank and combine both techniques. And that way, knowing anatomy and knowing about some surgical steps for microsurgery and endoscopy, I didn't deal with that. You can get access to the petrous bone, petroclival region, pontine region, lateral wall of cavernous sinus, and also infratemporal arteriopalatine fossa in case you do endoscopic approach. Thank you very much.
Thank you, Miguel. There is any question or comments? I don't see any question from the floor. All the panelists have to make comments. If not, may I make a comment? I think that the previous lecture and your lecture are showing as this kind of approach should be tailored for each pathology and this patient. It's not a standard approach, it has to be validated by what Floris said, the pre-op navigation to understand what we are going to do and to choose the right patient, both for endoscopy, both for microscopic. That's my contribution to this beautiful lecture that we have. Any other comments or question? If not, I will pass to my co-chairman, Jevasi, for the last three lectures. Please, go ahead.
Thanks very much. It's a real pleasure to have Henry Schroeder speak next, who's been on this committee for a very long time with excellent presentations. We're moving from the cavernous sinus and the petrous apex now into the posterior fossa. Henry will be talking about vestibular schwannomas, which is a common operation for all of us, but one where really understanding the anatomy and surgical skill makes a big difference, like all skull-based cases. So Henry, thank you very much for joining us. We're looking forward to your presentation.
Thank you for this nice introduction. It's a great pleasure to see you all. Imad, thank you for the invitation again. Great pleasure to be here. And my topic is vestibular schwannomas. It's working? Yeah, you see it?
Yes, we do.
Okay. So some considerations anatomically and also technically. So anatomy, the vestibular cochlear nerve and the facial nerves are the nerves which are involved in vestibular schwannoma surgery usually. And the origin of the nerves is of the vestibular nerve and the cochlear nerve is in the lateral part of the posterior fossa, the nuclei of the cochlear nerve and the nuclei of the vestibular nerves. And then the nerve exits the brainstem at the level of the pontomedullary sulcus. The facial nerve is similar. The nuclei is located in the pontine area. Then it has the inner knee going around the nuclei of the abducens nerve. And then the exit point is here down at the pontomedullary sulcus. And this is an endoscopic visualization. This is the pontomedullary sulcus here. You see the abducens nerve here. The nerves are usually very close in relation to the ICA. And you see here the facial nerve. And what is not well known by the radiologist, for example, is that the nerve is attached to the brainstem for about 1 centimeter. So when they make an image and see the cisternal part of the facial nerve, usually they don't know that the facial nerve is exiting the brainstem further down. So if there is a caudal compression, for example, hemifacial spasm, frequently they overlook it and say the facial nerve is not in touch with this vessel. Here again, you see this is a facial nerve. This is a intermedius nerve. The intermedius nerve is sometimes, from the beginning, very close to the facial nerve, sometimes incorporated, so you cannot differentiate it when you look at it. But sometimes it's running in between the vestibulocochlear nerve and the facial nerve. That's why Endo calls the intermedius nerve. Then we come to the cisternal part of the vestibulocochlear nerve and facial nerve. Here is the view to the dorsal side. So this is all vestibular nerves, and you see the ICA. The ICA loop sometimes goes into the internal auditory canal and makes a 360-degree loop and coming back. And here you see the glossopharyngeal nerve. Again, sometimes when you look at the nerve, you see already a separation into the superior vestibular nerve and the inferior vestibular nerve. But frequently it's just one nerve and you cannot differentiate where is the vestibular part and the cochlear part. So again, a view to show the relationship between the internal auditory canal, where the vestibular cochlear and facial nerve going into, and the jugular foramen, where you see the first branch, the glossopharyngeal nerve, and then the vagus nerve. And again, here you see the ICA making a loop into the internal auditory canal. When you have larger tumors, the nerves may be very displaced and sometimes very difficult to judge where is the nerve running. Usually the facial nerve is displaced superiorly and anteriorly by the tumor, and the cochlear nerve is displaced more caudally. But this is very variable. Then we come to the intrameatal segment of the nerves. You see the vestibular nerve, the superior vestibular nerve and the lower vestibular nerve. And if you cut these nerves, when you remove the tumor, you see in the upper corner the facial nerve and in the lower corner the cochlear nerve. And then finally, with a 45-degree endoscope, you may have a look into the fundus. You see here the transverse crest, and you see the facial nerve and the cochlear nerve. In the fundus of the internal auditory canal, the topographical anatomy is very fixed because there are canals and this cannot be moved even by a tumor. So superiorly in the anterior location, there is a canal of the facial nerve. Then we have the area of the vestibular superior nerve. Then we have the transverse crest. And in the lower portion of the fundus, anteriorly located, is the cochlear nerves entering to the cochlea. And we have in the posterior part the area of the inferior vestibular nerve. So in this area, you always can identify the nerves very precisely because this position cannot be dislocated by a vestibular schwannoma. There are different classifications of the tumors. The intrameatal part is usually type 1. Type 2 mates, the tumor is extending out of the internal arterial canal into the fundus. And then grade 3 means it reaches the brainstem, and grade 4 are the larger ones which compressing the brainstem. And the location of the facial nerve, because it's usually anterior to the tumor, the nerve is displaced anteriorly, or it is displaced superiorly, or more caudally. But I have also 2 cases where the facial nerve was completely dorsal, on the dorsal surface of the tumor. And I could not visualize it. I just found it with stimulation because it was a very thin nerve, like an arachnoid plane just. So the concept of endoscope-assisted microsurgery is of using the microscope and the endoscope. And when we dissect vestibular schwannomas, I fix the endoscope here with this mechanical holding arm, and then I have both hands free and have the same bimanual dissection as I have it with a microscope. I use very small optics, 2.7 millimeters in size, because they fit easily in between the nerves. Different angles of view are available. And then, of course, you need also angulated instruments if you see tumor under an angulated endoscope. Otherwise, you only see the tumor, but you cannot deal with that. Image 1 HD camera for me is still the best available visualization technique. I find it better than 4K even. And the advantage of the endoscope is when we deal with tumors in the fundus and we want to preserve the hearing, we must not open the vestibular and the posterior semicircular canal, but we have to drill the posterior wall of the internal arterial canal. And then there is still a blind corner to look to the fundus when you make a retrosigmoid approach, and that is a problem. And for that, the endoscope is very helpful. So you see here's a view with an endoscope into the fundus. We see the facial nerve, we see the cochlear nerve running here, and this is a transverse crest. And also what is very helpful in my mind is that we look for open air cells. If you look with a microscope, you have a tangential view. It's very easy to miss small openings of air cells in this area, but with an endoscope, you can really nicely see it, and then you can deal with it. So the surgical technique is that we start with a microscope, then we use the endoscope for freehand inspection. And when we see tumor, we fix the endoscope with a mechanical holding device, and then we dissect the tumor. And of course, the monitor should be in straight line to have an ergonomic working. Monitoring is essential. So we always monitor, of course, acoustic evoked potentials, and then we have in facial EMG. Sometimes we use trigeminal EMG and sometimes lower cranial nerves, depending on the size of the tumor. So at the beginning, before I touch the tumor, I take this electrode to stimulate the surface of the tumor and to look for the facial nerve. And the dissection, usually I try to dissect perpendicular to the course of the nerve. So I try to dissect in this direction. I have 2 forceps. One is holding the tumor and one is grasping the arachnoid to dissect the nerves in this perpendicular direction to the course of the nerves to avoid stretching of the nerve. Of course, in the fundus, it's not possible because then you have to dissect in the direction of the nerve. What is an indication for treatment? Usually, if we have young patients, they have a good hearing, they come with a small tumor, we advise for surgery because if you have the best possible hearing, then you have the better chance to preserve the hearing. This was a teacher of sports, and he had a small tumor. It's a hearing loss a little bit. And I said, yeah, you are young. I would advise for surgery. But he asked me, can I do my exercises on the high bar again? I said, I'm not sure whether this will work because the vestibular fibers are engaged. And then he refused the surgery, and you see it's now almost 20 years, and there's only a minor growth of this tumor, and he has still a good functional hearing. But you know, in most cases, this is not the same course, and most of the tumors I have in follow-up after 1 or 2 years, usually they start to grow. But it's an option which should be known by the patient. If I see such a tumor which is growing into the cochlea, and this lady has already impaired hearing, we don't advise for surgery and also not for gamma knife, because both procedures will lead to loss of hearing. So we just watch a natural course. And if the patient has severe dizziness, disabling vertigo, then we would advise for surgery and would do it with an otologist together and place a cochlear implant to preserve some of the hearing. So in these small tumors extending to the fundus, we use the supine position with the retrosigmoid approach. This is the position of the patient. So we elevate the head a little bit. We don't rotate too much, but we turn the whole table. So then the cerebellum goes down and I don't need any retraction. Of course, the monitoring of the nerves is done, and this is the incision. We usually make it more curved because I want to look into the fundus. For hemifacial spasm, we make a straight incision because we look down to the brainstem, but here we want to look to the fundus in the petrous bone. We do a middle retrosigmoid craniotomy. It's always, for me, very important that I see the margin of the sigmoid sinus and then here the knee of the sinus going to a transverse sinus. That I think is very important that we go very close to the margin of the sinus to have the least retraction possible. What I like to use is a suction spatula. We connect the tube for suction, very low suction, and then I place it in the deepest field of my surgical field. And then I can irrigate and can dissect with both hands with forceps, and I don't need to hold the sucker. So it's like a third hand. Suction spatula is down here, and I have 2 forceps. My assistant is irrigating all the time to give me a nice plane. For vestibular schwannomas, I think it's very important that you really precisely see the plane, and with the suction spatula, I can hold 2 instruments. I can dissect the nerve without the need of holding a suction. Just one example, this was a 20-year-old male. He had a hearing loss on the right ear, and the MRI shows on the left side a tumor. So this is a disabled hearing. So what would we advise? Some people said, yo, this is a clear case for gamma knife. It's a small tumor. And he also gets this advice, but he was not happy with radiation. Then he came to me. And here you see he's a very good hearing on the left side and a very bad hearing on the right side. So the aim should be hearing preservation. And if you look to the long-term outcomes after gamma knife radiosurgery, we have a very good tumor control rate even after 15 years. But if you look at hearing preservation, it's only 1/3 of the patient after 15 years. So that's why I said to him, we can try a surgery with acoustic work potentials, and if they will decrease, we will immediately stop with the surgery. And this is the amount we have to drill of the internal aortic canal, but we should not open the semicircular canal and the vestibule. So this already, the canal is open. You see the vestibular nerves here, and here's the tumor. The tumor is dissected under microscopic view in the medial part of the tumor because you can see it very nicely. I think it makes no sense that you start with an endoscope from the beginning because of the dry 3-dimensional view. And then you see now it's a blind dissection. And then I switch to a 30-degree endoscope. I fix it to a mechanical holding arm. And then under direct visualization, I can dissect the tumor from the residual vestibular nerve. So it's no direct contact to the facial nerve. It's just contact to the residual fibers of the vestibular nerve, and under monitoring of acoustic evoked potentials and facial AMG, I can dissect this tumor. Then with a 45-degree endoscope, we look to the fundus and you just see residual fibers of the vestibular nerve, but no tumor remnant. Unfortunately, we could preserve a good hearing in the left ear and no recurrence so far after the surgery. So another patient has also a tumor, small tumor in the fundus on the right side. It's not going complete to the fundus. That is a good sign. has a good hearing. Again, we have to drill the internal auditory canal, and then we need the endoscope to look to the fundus. So you open the canal with a high-speed drill, then we cut the dura in the meatus, and you see already here the vestibular fibers split by the tumor. So we dissect the tumor, and then again you see, you cannot see very well. It's very important that you first develop the plane between the vestibular nerve, and then you can mobilize the tumor under endoscopic visualization. But at first you have to dissect the tumor, and you have seen, we see here the facial nerve and down the cochlear nerve. And when I came after the surgery in the evening, he was talking to his girlfriend with the handy on the right ear. So this was a good sign. But then it happened. I know it can happen, but it is rare, fortunately. But he deteriorated in the night. He had like acute hearing loss, and we sent him immediately to the evoked potentials. And you see the audiometry shows that he has secondary hearing loss after surgery, and this can happen. It's not frequent, but I had some cases. They had initially a good hearing, and then in the first post-op days, it may deteriorate. But 5 years later, he has still functional hearing. So what is the strategy in large schwannomas? Initially, we also place the supine, but then when you dissect, you have all the blood in the surgical field, and you can also not use the section spatula because you cannot place it in the deepest point. And that's why you always need to have the suction and the dissector, but always you have the blood inside. And this, of course, I think is not a good idea. That's why for the larger tumors, we use the semi-sitting position. And we have for protection from air embolism, this endoesophageal echo, which is very sensitive. It detects air bubbles. The incision is a little bit larger because CSF has to go down by irrigation. The only problem is we have this retraction, which might hurt the cerebellar surface. But the main risk is the pneumocephalus, which may occur especially in older patients with wide ventricles, and the risk of air embolism. It's not too inconvenient because we can have here a hand rest, and then we can work when the arms are long enough. This is an 11-year-old girl which came this year before Christmas. And we sent her home for Christmas celebration. Then in January, we did the surgery. You see the huge tumor. She had not recognized hearing loss, but dizziness and headache. And you see she has still functional good hearing on the right side. And we place her in this position, makes this opening, and then we do the surgery. Also in the large tumors, I start with the opening of the internal auditory canal with a high-speed drill. I try to make a 180 degrees unroofing of the canal. Then I go with the electrode on the surface or the surface of the tumor to look for the facial nerve. Then we coagulate the tumor capsule. We take specimens for the histological evaluation, and then we make a vigorous debulking of the tumor with the ultrasonic aspiration. And then we come to the plane of dissection. Here again, you see the benefit of the sitting position. Under continuous irrigation, we dissect the plane around the tumor, which is very helpful because you always have a good view. Identification of the facial nerve in the internal auditory canal, and then further dissection in a bimanual way. Under constant irrigation, you see the cochlear nerve is identified and is dissected perpendicular to the course of the fibers under constant irrigation. This gives you this nice plane, which is so important to see. Then we come to the facial nerve at the brainstem. Again, a lot of irrigation to keep the plane. Then again, debulking of the tumor and further dissection. 2 forceps, irrigation, and you see how important it is to preserve this arachnoid plane, and you go really along the tumor. Here again, you see facial nerve is coming, and it's very adherent here. But because of the good identification of the plane, we could grasp the arachnoid and could dissect the tumor from the nerve from the tumor. And of course, we have the monitoring on. If I would have experiences bad prognostic trends, then of course I would stop. But in this case, we were lucky. We could dissect carefully, millimeter by millimeter, the nerve from the tumor surface.
Henry, we're just over 18 minutes.
Yes, so I have 4 more. Okay, and then finally, we had a gross total resection and stimulation of the nerve. And then we look here with the endoscope, open air cells, and also there was a small residual tumor, which was not visible under the microscope. I could dissect it under endoscopic view. So the larger tumors, I think, should we always aim for a gross total resection? When I was young, I was taught is a benign tumor must be totally removed. It doesn't matter what is the facial nerve. I did this 10 years ago, and you see this lady has slight palsy, but disfiguring. It's not nice. It's not cosmetically what we want to have. And that's why I changed my strategy. This was a 17-year-old lady presenting with this tumor, and she was told she will have definitely facial palsy. There's no chance. And then she came to us and I said, we will try our best to avoid it. And we expose the tumor, debulk the tumor, open the canal. And then when we dissect the facial nerve, we had the problem that the nerve was really sticky. And each attempt to dissect it in the way we did it in the surgery before was not possible. And that's why we left a very small, tiny piece of the capsule. You see, we can dissect here. It was a very bloody tumor, and the sitting position was again very helpful to dissect all this, the tumor away from the brainstem. And here was the facial nerve, and then it becomes very sticky at the area where the facial nerve goes over to the internal auditory canal. And then we just took the Kuse and we make the tumor very thin and left it. You see here is a small area of tumor, but it's 7 years after surgery and was not growing so far, fortunately. And she has that smile, what we want to have. Another case, large.
Sorry, Henry, we're over 20 minutes now.
What?
We're over the 20 minutes. I was wondering if you could conclude for us, please. Thank you.
We can stop anytime. This was just my consideration that in the large tumors, I think we should not be over aggressive, and we should always preserve the function. That I think should the main task. And the endoscope, I think, is very helpful in the vestibular schwannomas, especially when we look to the fundus in patients where we want to preserve hearing. So thank you for your attention.
Henry, thank you very much for a fantastic talk. There's a question here about how you would locate the projection of the porus along the posterior surface of the temporal bone when you're drilling. I think when you're drilling the porus in a retrosig approach.
Yeah, usually it lies parallel to the tent. I just drill it, and when I found the dura, I follow the dura. Sometimes in the smaller tumors, it's a very thick bone. Sometimes the larger tumors, it's dilated. So I always drill in the middle, where I see where is the tumor going into the fundus. You can take a hook, a nerve hook, go in and look where is this opening, and then I drill until I find the dura, and then just follow the dura. So it's very, very easy.
So thank you very much. There's another question there. I'd be grateful if you could answer it in the chat. And I'd like to introduce our next speaker now. Our next speaker is, and if you could stop sharing your screen, thank you. Is Professor Amer Deshadi, who is the professor at the Zucker School of Medicine, is a real expert in skull base and cerebrovascular surgery. Thank you very much, Professor Deshadi, for joining us today. He'll be talking to us about the far lateral approach and the anatomy and technique involved in that. Is Dr. Deshadi here with us?
Yes, thank you. Thank you very much. And Imad, thank you very much for inviting me to this panel. It's truly an honor to be here. I was asked to talk about the far lateral. Let me share my screen and please tell me if you have it.
Yes, we've got it. Thank you.
Do you see my screen?
Yes, we can. Thank you.
Okay, very good. I think specifically because there are many, I assume, trainees listening to this series of talks, The far lateral approach is obviously anything in neurosurgery is complex, but at the same time, far lateral approach, along with the orbitozygomatic and anterior clinodectomy, is really the two most common Scalbis approaches that we do. So I always tell our residents and my fellows that the far lateral for you should be like a pterional craniotomy. You should simplify it as best as possible and use it whenever it's needed, because it's truly a beautiful approach. It's a relatively quick approach, and it gives you an excellent exposure of the region of interest. There are different terminology for it, and we're going to go over the anatomy, cadaveric dissection, and in some cases. If you look at this, you see there are many different ways of naming this approach. But all I think we should remember is that there is really one approach, which is a far lateral approach. Anything else is just adding adjective to it, which doesn't necessarily helpful. And the other one that is different, it's the extreme lateral approach, which is basically the elite approach, which is extreme lateral infrajugular transtubercular exposure. And that is another subject of this talk, and I'm not going to talk about it, but this is really what makes another different approach compared to the far lateral, because the more we work on that extreme approach, we will get anterolateral. And this is the approach that would be helpful, for instance, for paraganglioma surgery or some hypoglossal schwannomas. But for the sake of the far lateral approach, we will describe the surgical exposure. This is basically simple, exposing the muscle in the posterolateral aspect of the craniovertebral junction, exposing the C1 transverse process, identification of the vertebral artery, which is key after removal of the C1 arc, a half part of it, and then addition of a suboccipital craniotomy and drilling of the condyle as much as needed. We almost never need to drill too much, because you will see that the exposure that you need is obtained by just a relatively minor to moderate drilling of the condyle. Dr. Harris popularized this approach. You can have this reference if those who are not familiar can read this initial paper. And the indications are listed here. You can read by yourself. I'm also, as you mentioned, a cerebrovascular surgeon. I deal with a lot of vascular pathologies, but it's also helpful for all the lesions that are in the anterior aspect of the foramen magnum, lower, and even middle third of the clivus, jugular foramen, and so on. The beauty of the far lateral approach is that it gives you this caudocranial direction that you cannot get with more simple exposures. You can see the yellow on this picture that shows you how the far lateral approach gives you an access really from below all the way up to the 7 and 8 nerve and even higher, but the goal is to really get anterolateral or anterior. And you can see here the difference between the two pictures. The left side shows the retrosigmoid and the right shows the far lateral after the vertebral artery has been exposed. And you can see how the view here is more caudocranial, and you have an oblique but very long axis to the anterior and anterolateral aspect of the brainstem and the brainstem itself without any retraction on the cerebellar or brainstem tissues. Here you can see the amount that is usually needed for a transcondylar exposure. On the left, you can see the hashed area is about 8 to 10 millimeter in length and about 3 or 4 millimeter in width. That's all we need in vast majority of transcondylar exposures. It's basically not much. And as long as you identify where is the condyle, the most important thing is that you understand where is the condyle, because sometimes people drill and they think they have drilled the condyle, but they have not even reached the condyle. Or if you don't realize, you might drill too much and then get too far in it. But about 20% of condyle resection postero-medial is really what we need to get the exposure that is necessary for the most anterior aspect in the brainstem. And exposure, again, it starts by dissection of the cervical muscles. This part can be done with a monocautery. You can see different muscles labeled, semispinalis, splenius capitis. And we can continue that until we get to the lower level or deeper layer of muscles, which is really the combination of the muscle on the left. You can see the superior oblique, inferior oblique, and rectus capitis posterior major. And this makes the suboccipital triangle. And when I get to this part, and usually the occipital artery, the muscular branch of the occipital artery is identified just superolateral to the superior oblique muscle. So when you see the muscular branch of the occipital artery there, you know that the superior oblique muscle is there. And then you stop working with the cautery, and at this point you use basically bony dissectors or scissors to cut the attachment of superior oblique muscle, and then identify the groove of the C1 and identify the vertebral artery. So this is the area that one can get into danger of injuring the vertebral artery if this part is done with monocautery. So that's very important. It's a basic information, but it's very important. And it can happen very easily if people are not paying attention to this. Then you have the vertebral artery exposed with the venous plexus around it, and depending the amount of drilling that it's needed, that vertebral artery can be mobilized. The C1 lateral mass can be drilled, the groove of the C1 can be removed, and the vertebral artery can be mobilized, lateralized, or medialized, depending on what pathology are we dealing with. Vast majority of the time, I do not medialize the vertebral artery. What we do is that we separate, liberate the vertebral artery, and we push it more laterally, and that will give us a better anterolateral exposure to the brainstem area. And you can see here, these are different maneuvers that we can do with the vertebral artery. And I'm going to go ahead and show you the exposure that you can get. Now, in the intradural stage, once the incision is done, the incision in the dura starts on the cerebellum and comes all the way down, parallel and close to the vertebral artery, and follows in the dura of the spinal cord. And then you retract the dura with the vertebral artery laterally. This is what is needed in vast majority of cases. Now, there are different amount of condylar resection and where do you want to work. Usually that simple transcondylar, which is about 20%, 30% of drilling is enough, but you can also work supracondylar, like here in this picture, as you can see, working depending on the pathology, or you can work really paracondylar by drilling way more. And as I said, this is not necessary. I have maybe done this procedure only once when I removed, or twice when I removed more than half of the condyle, and then you need to do a few stuff like that. So positioning is a lateral position. This is the incision. The hockey stick is a traditional incision. I don't do hockey stick only if I use an occipital artery as a bypass donor. Otherwise, usually I do a curvilinear incision behind the ear, the same for retrosigmoid, and extend it all the way down to C2. And some anatomical exposure. Again, this is from our lab. This is my fellow, Dr. Prashant did that. You can see here the vertebral artery, C1, and the C2 nerve root. These are the landmark that you would find when you do the exposure of the far lateral approach. Now, look at this picture. This is what the picture under the anatomical illustration. That's what you would like to see. You want to see the spinal cord. You want to see the C1, C2 junction in a true far lateral approach, because that will give you that caudocranial axis. And the most important thing is that by doing so, and by coming with this angle, you have zero retraction on the brain structures. And that's very important. This is a case where I mobilize the vertebral artery medially. It's rare that I do that, but for this particular case of meningioma, I mobilized the vertebral artery medially by completely separating it from the lateral mass of C1. And you can see with the virtual augmented reality here, you can see where the vertebral artery on the low right picture has been medialized and the tumor on the lateral side of it. But it's rare that we need to do that. I'm just showing this picture, but it's rare that we need to do that. Now I'm going to go through some case example from meningioma to aneurysms, calf-mal, and
hello, ladies and gentlemen.
So this is a patient with a foramen magnum meningioma that had increased in size. Can you please confirm to me that you see the video playing?
Yes.
Yeah, we do.
Thank you very much. This is a meningioma that it was a smaller. I watched this patient for a few years, and it got bigger after 5 years with balance issues. And you can see the tumor is larger, compressing the brainstem, some edema in the brainstem. So a far lateral exposure was done for this tumor. And you can see here, this is the drilling of the condyle. This is that about 20% drilling that is done with the diamond drill. And you can see the drill. Do you see my arrow?
Yes.
Okay, this is the area of the condyle. And this is drilled enough to get us this exposure. The vertebral artery is right here, and the dura is open in a linear fashion. And you can see here the vertebral artery coming out or into the cranial space. And you can see how we are more lateral than that would be only if you mobilize the vertebral artery medially. But this will give a perfect access to the base of the tumor. You can see there is no retraction on the brain. The vertebral artery is here, devascularizing the tumor from the base on the clivus. And using the sonopet, you can see the branch of the 11th nerve here. And it's a relatively vascular tumor. So you can see with the minor dissection getting around the capsule of the tumor. And we have a complete direct access all the way to the anterior clivus here, as you can see. You can see this is the venous plexus of the anterior clivus. No retraction on the brain. Is a true far lateral exposure with only about 30% drilling of the condyle. And then it's a matter of just getting around the tumor, debulking it and separating the tumor. And finally, this is the dura of the base that I removed as much as possible, but we can never get a Simpson 1 resection on these because it's difficult to microscopically cure this disease at the anterolateral clivus, but we remove as much as we feel that it's good, and it's at least a very good Simpson 2 resection. And you can see this is at the end, cavity, vertebral artery, and this patient had some swallowing difficulties, needed an NG tube for a few days, but no need for PEG, and a completely normal neurological exam after. And this is complete resection, no evidence of any dural residual disease. Another patient with a cavernous malformation in the pontomedullary junction, a young patient, you can see the developmental venous anomaly. This tumor, this cavernous, as you can see, is high. Some people would say, well, why don't you do a retrosigmoid? But I think in order to get that anterior at the safe entry zone that is just lateral to the 6th nerve, which is basically the lateral, the inferior lateral pontine safe entry zone, the best access is a far lateral. Again, here, a drilling of the condyle. This is a left-sided approach. Suboccipital craniotomy is done, and C1 has been already removed. You can see here, this is the vertebral artery right there. And we drill the condyle. Vertebral artery is right here. I'm just cutting right adjacent to the vertebral artery. You can see this is the vertebral artery here. And then the dura is open. So again, we don't need to expose the vertebral artery more in this case. This is an intrinsic lesion in the brainstem, then opening of the dura. And this, you can see this axis will give you exposure to the 7th and 8th nerve. We have the pontomesencephalic vein. You have the 6th nerve, the origin of the 6th nerve here, right there. You can see the 6th nerve and ICA. And we know that this is a lateral pontine safe entry zone. There is no evidence of cavernous malformation, but with the use of navigation and anatomical knowledge, we will stimulate also to make sure I don't get any motor fibers. You can see here the 12th nerve down there, 12th nerve, 11th nerve, and we go back up again. This is the 6th nerve. And then we create a PO entrance to the brainstem, and we get to this cavernous malformation. And once we identify it, it's just a matter of coagulation, separation, and taking it out. So you can see this caudocranial axis will give an unobstructed, is a long trajectory, but is unobstructed, retractorless, and completely direct to the cavernous malformation. Retrosigmoid would not give you this exposure. And this is where the lesion is out. And you can see at the end, this is the cavernous malformation resected in total. This patient double vision improved. And at a few weeks, this patient was completely neurologically intact. This is post-op. Now, pica aneurysms, depending on their type, this is a pica aneurysm, which is a large pica aneurysm. You can see in a relatively young 65-year-old patient, incidental finding you can see is a large pica aneurysm, has the pica coming from the origin of it. We decided that surgery is a better option for this patient. You can see how the aneurysm looks like. It's a dominant left vert. The right vert is very small, so we have to be extremely careful with this left vertebral artery. You can see the right is almost nothing, so this patient cannot survive if there is an injury to the left vertebral artery. So again, this is an exposure. This aneurysm is at the anteromedullary segment of the pica, and this is the exposure that we get through, and the aneurysm is in the suprahypoglossal component, above the hypoglossal nerve. So here we can see again the condyle resection. It's not really a resection, it's drilling, it's thinning the condyle for about 20%. You have the left vertebral artery again here. Suboccipital craniotomy is done. But this is the way we open the dura in a linear fashion. And you can see this is exposure vertebral artery right at the entrance. So you see we don't need to drill any further. We are right on the vertebral artery and the aneurysm. Separation of the aneurysm from the brainstem. Lots of perforators at the first segment of the pica that needs to be dissected. Branches of the 11th nerve and the 10th nerve that when we clip, we have to make sure that they are not in the clip. This is a temporary clip on the vert. This is a very important occlusion time because that's really the dominant vert. So that has to be done very quickly. I was ready here to give adenosine if it was necessary, And then this aneurysm was clipped with a fenestrated clip, having the pica into the lumen of the clip, and needed several clip adjustments to make sure that the whole neck is taken care of. And you see all these little rootlets of 10 and 11 should remain intact. And this way the aneurysm is completely clipped. Adding a last clip is a closure clip at the fenestration. And this is the final view. You can see again, completely unobstructed view that is attained by doing a far lateral approach. And this is a post-op showing patency of pica and exclusion of the aneurysm. A giant aneurysm, ruptured, partially thrombosed, with a, you can see that's only the lumen of the aneurysm, very small open. So in this case, I am having a far lateral approach from the right side, exposing the vertebral artery here more. As you can see, I'm completely skeletonizing and taking the vertebral artery out of the lateral mass of C1 and the groove. And here is the condylar resection, because in this case, I was planning to do a vertebral artery pica bypass for this giant aneurysm, partially thrombosed. And this is the drilling of the condyle, removal of the, bless you, removal of the edge of the condyle here, and the same opening of the dura. This is the thrombosed aneurysm, only the part that is patent. And you can see during this dissection, while I'm preparing for a more complicated bypass, the aneurysm bleeds, and that creates a sort of a change in the strategy. And after evaluating of the scenario, I'll see that the pica is extremely redundant. So instead of using the VA pica bypass as an option, I just cut a part of the aneurysm and disconnect from the thrombosed part and simply connect these two parts together, the proximal and distal part of the pica. Fortunately, I was lucky. This is a redundant pica and will allow me to just connect these two together as end to end. And the aneurysm was then debulked here. And that will completely cure the aneurysm. You can see the lumen of the aneurysm open and debulk. And this is the vertebral artery. And this is our pica re-anastomosis. And that's the CTA showing the exclusion of the aneurysm and the patency of the lumen of the pica. And finally, this is a case of a subarachnoid hemorrhage in a patient who had significant already spasm, as you can see. Another complicated pica aneurysm at the second segment at the lateral medullary junction. This patient was, in terms of donors, occipital artery was very poor, contralateral pica was very poor. Again, the only option here was a VA pica bypass if we wanted to save this pica. And the same thing as the previous case, exposure of the vertebral artery. Again, this time needs mobilization of the vertebral artery out of the groove of the C1. You need to get a good length of the vertebral artery if we entertain the idea of using it as a donor. And this is the pica. I use the radial artery here and the connection of the radial artery to the distal pica at the telovelotonsillar junction. And it's done. Once this part is done and the distal part of the bypass is sewn, then we cut the graft at the right length and we go to the vertebral artery at the V3 segment. Is trapped and it's opened. And this patient had actually an atheroma inside the vertebral artery. So I had to do an endoarterectomy inside the vertebral artery before connecting the vertebral artery to the vessel and the radial artery to the vessel. And this is an anastomosis at the proximal segment. So here we do a VA pica bypass. So we have now the prophylactic bypass. And then I go and there is a little bit of retraction. He's a patient with a subarachnoid hemorrhage. The patient's cerebellum was a little tiny swollen. And now we go here and try to get this aneurysm, as you can see here, at the origin. And I end up simply distally clip the aneurysm because there was a perforator coming right proximal to the aneurysm. So it's a distal clipping of the aneurysm without proximal clip and the bypass that take care of the pica. And you can see this is the ICG during the surgery. And what we can see is post-op pictures showing spasm actually got better. And you can see the post-op picture with complete exclusion of the aneurysm with distal clipping alone and the bypass taking care of the large territory of the pica. And this is the last case, a patient with a jugular foramen dural AV fistula. This patient had a hemorrhage and a Wallenberg syndrome and a very complex fistula. You can see the hemorrhage and a very complex fistula at the foramen magnum. mainly fed by the branches of the neuromeningeal trunk of the occipital artery and neuromeningeal trunk of the ascending pharyngeal, along with C1 and C3, lots of small feeders to this fistula. And this fistula was draining into this pontomesencephalic vein. I hope you see my arrow here. This is a pontomesencephalic vein, which is an unusually dilated vein. So this was embolized. Initial result was good, but within 6 or 3 months or so, when we did a follow-up angiogram, the fistula recurred because it just recruited from elsewhere. And you can see this is the recurrence of the fistula after a few months, and we already see that the vein that was very, very small recurred again. You can see the vein here. So we decided to go for surgery. This is exposure far lateral, and you can see your vertebral artery coming here, and you can see how flat this exposure is. So you can see this far lateral exposure. If we don't do the far lateral and let's say just retrosigmoid to get to foramen magnum, we will never get an exposure so wide, so panoramic, and retractorless. And you can see this is the vertebral artery coming. This is the branch of the 11th. This is the C1 nerve root. This is the vert here. This is all this abnormal venous channel that is making this patient that caused the hemorrhage and Wallenberg syndrome. And this is the point of the fistula. Once we have this exposure, the treatment of it is so simple. Just putting a clip at this DAVF at the origin from the dura, just above the vertebral artery. And is one of my fellows doing this. And then the most important thing is to understand the anatomy of fistula and understand where is the point of fistula. Once you get there and exposed, the treatment is simple and just separating. And you can see this caused immediately a change in the color of the fistula in front of the brainstem. It's immediately turned blue here. You can see here is completely blue. And we add a second clip as a booster because it's a very high flow fistula, and that will cure the problem. And you can see the ICG does not show any further flow. And this is a complete exclusion of the dural AV fistula. So we discussed about different pathologies: meningioma, dural AV fistula, brainstem cavernous malformation, and pica aneurysm that was treated through the far lateral with clipping and different type of bypass. And that's it for now, and I'm happy to answer your questions. Thank you.
Amir, thank you very much for a very nice talk and a very nice follow-up from Henry's very good talk before going into post-fossa. So I don't see any questions on the chat. Do our panelists have any questions? Otherwise, I will ask a question. Anybody from the panel has a question? While we wait for that, Amir, can I ask a question? I don't know if Vlad is here, but Vlad likes to talk about the enough lateral approach. And that's about drilling, not drilling too much when doing a far lateral, or drilling just enough, I should say. Do you think there's a difference between how much you have to drill for vascular cases compared to tumors where the tumor has made some space for you?
Yeah, I think effectively for tumors, specifically meningioma, sometimes create really the space for you. I reviewed last year a paper from Italy, and they really decide to do the for all foramen magnum meningioma from a midline suboccipital without condylar resection, and they get good results. I think it's more important to get the exposure, specifically if you're working inside the brainstem, like from brainstem cav mal, because there's nothing has created the space for you to work around it. But quite frankly, drilling 10, 20%, 30% of the condyle is completely harmless if it's done correctly. It does not take much time, and it will give you an additional light. And why not using it? What do we have to lose by just doing that if it's done correctly? Because the more exposure, the better it is. And as you can see, all these cases that I've shown, it's really a panoramic exposure. There's no need for brain retraction. And you have such an ample amount of room to work that I don't know why should not be. Obviously, we don't do it if it's not absolutely necessary. But definitely, you don't need to drill too much. Now, Juha always saying is enough, lateral enough, or whatever he was saying. But it's right. I mean, it's not a. The name is not important, and that's why I bring all those lists at the beginning, because people call it different things, and then they mix up a far lateral with an extreme lateral. But it's far lateral in the sense that it's more lateral than a retrosigmoid craniotomy. Now, the name, you can name it however you want. I think 20% drilling of the condyle is helpful. And it's also good for people, specifically for trainees and those at the beginning of their career. Every time you think you want to do a far lateral, get a post-operative CAT scan, thin cut CAT scan, and see what you have done. Because I did it myself, and I realized sometimes I did not do at all. I did not do enough. And then I learned by looking at my own CAT scan after surgery, when was the appropriate amount. And also you can learn whether it was really needed or not. But in order to appreciate if you have done what you thought you have done, follow up with the post-op thin cut CAT scan. Thank you.
Amir, can I ask one question, Amir, to you?
Yeah, of course.
Amir, I want to just, initiate a discussion about what is your indication, how much condylar resection, and when do you think that it is more than necessary and you will need to do fixation? First you answer, and then I will give you my thought on that.
Sure. As I mentioned, only one time I had to drill or remove the condyle for a patient with a chordoma that we fused after. Only one time. I really don't have the experience much with full or more than 50% condylar resection. But I think anything less than 50%, and in my series, I have done many of these over the past 10 years, I have never had a patient who developed instability for a far lateral approach that we drill less than 30% or something like that. And I don't know if Atul did that answer your question. I know that you you have a comment on the amount of
let me just answer that question. I completely agree with you. You see, occipito, the condyle, occipito-atlantal joint is the strongest joint of the body. Did you realize that? The ligaments which connect the occipital condyle with the atlas, if you see the bone, the superior surface of the atlas facet are loaded with ligamentous attachments. So if you remove 20%, if you remove 30%, if you remove more, the moment you open the joint, you are actually disabling that joint. You understand what I'm saying? So as long as you are in the condyle, it is all right. But if you go down and open the joint is actually disabled. But that does not mean that it needs fixation. If you remove the complete condyle also, the other side is so strong that there is no need for any stabilization. But in the long run, suppose you remove the entire occipital condyle and atlas joint on one side, there may not be need for a fixation immediately, but in the long run, if you follow this patient for 15 years, 20 years, slowly and steadily, he will develop a torticollis. So that is the situation. I'm not saying you fix it, and whether fixation is essential. Fixation is not necessary in condylar resection. This is my opinion.
Thank you.
Thank you, Atul. Thank you. So that was a very good discussion then. I'd now like to introduce our final speaker, who's Professor Mario Amirati from San Diego. You can see his slide up here now. He's going to talk to us about the minimalistic approach to the CV junction. Professor Amirati, thank you very much for joining us. It's a real pleasure to have you here today. Thank you.
Thank you. Thank you to Professor Kanahan and for organizing the meeting, and you for moderating. And I mean, it was a very nice talk. But as you know, there are several ways to skin the cat. And just to start, I would like to say that probably some of you know, but maybe most of you don't know, but in the late 90s, we used to do a lot of these combined presigmoid transversarium approach to the whole clivus and to the petroclival region, in which we exposed the vertebral artery over C1 and in the foramen transversarium, and sometimes we mobilized it in order to get a better angle of exposure to the lower and mid clivus. But lately, I would say probably in the last 7-10 years, I have realized that many of the operations that I used to do by being very aggressive with bone removal and doing some degree of condyle removal, condyle drilling, they're really not necessary. And we really contend that the majority of craniovertebral junction tumor may be safely approached using simple surgical approaches, provided that microneurosurgical fundamentals are used. Fundamentals, everybody knows what fundamentals are. They are the root of any human endeavor. And it's very important to define and to master the neurosurgical fundamental. The most important thing when you are dealing with benign extraaxial tumor is to respect the arachnoidal plane. Why? Because outside the arachnoidal plane or inside the subarachnoid space, there are usually the vascular and nervous structure that you need to preserve if you want to accomplish a good outcome. In order to respect the arachnoidal plane, you need to be able to separate it and to dissect it from the tumor. So you need to limit coagulation, because if you coagulate, especially at the interface between the tumor and the arachnoid, then you lose the crispness that allows you to do a good arachnoidal separation. Then you need to be able to approach the tumors from different angles. And because what is possible from one angle is not possible from another one. And sometimes, we have a tendency to overcommit to one direction of attack on the tumor. Then you must have a clear surgical plane and a clear goal, but at the same time, that must be mitigated by what you encounter at surgery. So you must be prepared to change your plane. And you must be aware of other modalities to control tumors, like radiosurgery. And radiosurgery is not only gamma knife. I mean, obviously, giving gamma knife a good dose of gamma knife radiation to a tumor in the cavernous sinus or to a tumor close to the optic nerve is not really ideal. But radiosurgery is also fractionated stereotactic radiosurgery, in which you give up to 5 fractions that allows you to be more gentle on the vascular and nervous structure that are inside the radiosurgical field. So I'm going to show you a couple of tumors. All these tumors, they were operated with the patient in the semi-sitting position, and all of them, the incision was either a midline incision or a paramedian incision, and we removed as necessary the posterior arch of C1, but we never went into the occipital condyle. But another 2 important things that probably is worthwhile to emphasize is A, that we removed the horizontal portion of the occipital squama all the way to the posterior lateral part of the jugular foramen. So that's the horizontal portion of the occipital squama. The occipital bone in the posterior fossa has 2 parts. There's a vertical part and then an horizontal part. When you remove the horizontal part, then you get to the craniovertebral junction, to the dural craniovertebral junction, number 1. Number 2, all these patients, they are operating in the semi-sitting position. So that allows you some degree of flexibility in surgery, because you may change the height and the inclination of the table. So that gives you a complete different perspective. You may change your angle of view. I just wanted, in the interest of time, I'll show you just two patients that I think are quite interesting. I think this patient here, number 10, is an hypoglossal meningioma. And I'll show you the... Now, this patient was operated again in the semi-sitting position, and the incision, it was the one that I described before. It's a very simple one, so it takes really nothing to to get to the tumor. And you can see here, the opening of the dura at the craniovertebral junction. You can see this one here is the dura over the cerebellum, and you can see that we have completely removed the horizontal portion of the occipital squama, and now we are opening the dura at the craniovertebral junction. And you can see the very nice exposure, the arachnoidal dissection, cross-spica. Sometimes we need to support the cerebellar tonsil, because as the patient is in a semi-sitting position, they tend to come down. And we always use neuronavigation, and we use the focal point. We use the focal point of the microscope as the virtual neuronavigation tip. So that's really, it's very ergonomically, it's very efficient. So you can see here we are approaching the tumor. And here we are starting removing the tumor using microsurgical technique, and then the debulking with the PUSA, and all the things that we all know. And let me see if there is anything. Yeah, this one is another patient that I really did not want to show now. So let me go back here. So this one is, this tumor here, this hypoglossal meningioma, was completely removed. And I will just show you let's somehow go back to the other one. But anyway, the tumor was completely removed, and the patient did well. Of course, she had a hypoglossal nerve deficit before surgery that she made unchanged afterwards. This one is probably even a more interesting case. This one is a patient with a small tumor we thought was a meningioma that is all the way in the anterior portion of the foramen magnum. And again, we have done the same exposure. And you can see again the posterior fossa, the dura covering the cerebellum, and the dura of the craniovertebral junction. And this one here is the receptor supporting the tonsils. Again, open of the arachnoid, we get all the CSF out. Of course, another advantage of the 760 position is that the CSF gets out. So, and you are able to keep the arachnoidal dissection without need to suction or to do any other maneuver. So you can see this is the cervicomedullary junction, that the cerebellar tonsils, that's pica. We use neuronavigation to identify a good angle of attack, and then we use the endoscope in order to confirm, that this is a good corridor to attack the tumor. And then once we have confirmed that, then we start working on that. And you can see that the only retractor that we use, and I really think that retractor is getting a very bad reputation today. I don't think it's a four-letter words, So I think that as long as you do it in a judicious way, retraction is very fine. And you can see here, we are approaching the tumor, and we are removing the tumor using, as usual, a combination of microsurgical technique, and we're also using the PUSA to debulk it. But this one is a very small, as you can realize, it's very high magnification. It's a very small window. It's probably less than 8-9 millimeter. Yeah, we just let it play for a little bit more. And again, you can see the advantage of the sitting position. The bleeding from the meningioma just doesn't need to be coagulated because it just drains down. So that really makes surgery easier. And also, you don't need to coagulate. And as I said before, coagulation is something that we try to avoid as much as possible because that it takes away the crispness of the surgical plane. And here again, and this tumor was interesting because we discussed how to operate this tumor, and many people were skeptical that we could get to this tumor with a simple, approach, and there were consideration of doing a extended endoscopic approach with removal of the odontoid. And, the patient then decided to select this particular approach. And that's why and that's the video of the operation. You can see here, the tumor has been removed. And right now, I think there are a few seconds where we place again the endoscope inside just to to make sure that we have removed completely the tumor. And when we use the endoscope, we inject the image of the endoscope into the ocular of the microscope, so we don't need to move our head and look up to the endoscopic image. So you can see here we have not disturbed anything. That's the endoscope going in and showing that the area, the tumor has been completely removed. And we were quite happy with this resection. And I think the next few seconds, next 10 seconds, will show you your pre and post-op MRI showing that the tumor has been completely removed. And now I just would like, for the interest of time, I'm just going back to the text slide. And again, so it's very what we wanted to show is that if you respect the arachnoidal plane, if you limit coagulation, if you approach tumor from different angles, if you use technology appropriately, like the neuronavigation, using neuronavigation under the microscope, really, you cannot do it using a handheld probe because A, that's ergonomically, it's very ineffective. And B, you need to move back and forth from looking into the ocular and looking to the navigation screen. And also there is a need for a clear surgical plane. And again, you need to be prepared to change your plane and be aware of other modalities to control tumors. And remember, radiosurgery is not only single fracture radiosurgery, but radiosurgery, especially for skull-based tumor that are close to vital structure, optic nerve or other important nerves. There is fractionated stereotactic radiosurgery that is very effective and that has certainly lower morbidity than gamma knife, unless you decrease the dose of the gamma knife and then you decrease the chances of curing the patient. So if the conclusion is that, and I really liked very much the talk by Amir Dedashi, but if microneurosurgical fundamentals properly mastered, then the majority of craniovertebral junction tumor may be safely operated using what we think are minimalistic surgical approaches. I think the surgical positioning is very important. The semi-sitting position may be changed. You can incline. You can change the angle of the table, and by changing the angle of the table, you change the viewing angle into the surgical field from a flat one to an angle that may go from down up and from an angle that may go from lateral to medial. So I think if you use all these surgical technique and surgical if you want to call them tricks, call them surgical tricks, then you would be able to really expose a lot of this tumor and take them out very effectively using very simple surgical technique. When you do the extensive dissection of the suboccipital muscle that Amir so brilliantly showed, patients do have a lot of pain post-op, a lot of pain. And I know that from my personal experience, because as I said, in at the beginning of this century, we used to do a lot of this approach, and the patient really they had a lot of pain. Doing a simple surgical incision, either midline or paramedian, it's very well tolerated by the patient. So I will conclude my talk now, and if there are any questions, I'll be glad to answer them.
All right, Mario, thank you very much for a very good talk. I was wondering if you could just stop sharing.
I have a comment, Sanjeeva.
Yes, of course. Imad.
Yeah. Well, to the two talks, I have wonderful talks. Thank you, Amir, and thanks, Mario, for the grand talks. In my practice, just for the sake of giving a message to the trainees, of course, they should learn the procedure. Sorry?
No, I'm trying to stop sharing. I'm working on that, so.
I can do that for you.
Yeah, please.
Yeah, for the trainees' sake, you see, I rarely do the vertebral artery transposition. This is one thing you should be aware of it, except in extreme cases. And I don't think for the last 6 or 7 years I have done a transposition of the vertebral artery. The far lateral and lateral, all these nomenclature, it will confuse all the elite. I think just to make it very simple, the lateral approach will be adequate, and the tailored approach is the most important. If you don't need to drill, you don't drill. If you want to drill 20%, and rarely you need to drill the whole facet, except on some giant aneurysm, as my colleague showed. The other important component, the muscle dissection, I agree with Mario. I don't do this anymore. This is a painful, it becomes a painful procedure. And you will manage to, if you need even to drill some of the facet joints, 20%, you don't need to do this muscle dissection. This is the second point. The third point, very important, the ligamenta denticulata. The denticulate ligament is very important if the stoma at the junction or go below the C1 to release the cord by cutting 1 or 2 ligament denticulata. It gives you mobility and it gives you additional space. And the last things, of course, microsurgical technique and arachnoid was very well described now by Mario. And tomorrow, I think Vladimir has a whole talk on arachnoid, and it's important in the dissection. The endoscopy has added, it gives you a long arm of visualization. So in some cases, you might add the endoscope if you need for a residual tumor, and you can still go for a simplicity rather than complexity of an approach would help the hybrid use of endoscopy. These are my points.
Yeah, thank you very much. I think it's very important also to emphasize that the sitting position that has been used in all these cases is a dynamic position. So a little bit like Vinko Dolenc, when he described the approach to the cardinal sinus, he emphasized the movement of the table, because by moving the table, you sometimes change completely the surgical field. So I feel that that's something that really has helped us a lot in approaching this tumor. And of course, the dentate ligament, I am sure you saw it in my video that we cut the dentate ligament because that really mobilized, as you said, the cervicomedullary junction. But I think also it's very important. Many trainees, they do not know that to remove completely the horizontal portion of the occipital squama. That's a very simple surgical procedure, but that really brings you to the craniocervical junction. Otherwise, you leave a window of bone, a strut of bone there that hampers your ability to reach that area.
I think Atul has a comment to make as well.
Yeah.
Can I make
Thank
a
you,
comment?
Sanjeeva. Thank you, Sanjeeva, for that opportunity. You see, I must, I was initially doing what Amir is doing, like extensive exposures. I was even mobilizing the vertebral artery, condylar resection, extreme lateral, and all these things for tumors located in front of the brainstem. But I must say, and I agree with Mario, that sitting position, if you can adopt and if you are comfortable, if you can do sitting position or semi-sitting position, you can really have a wonderful panoramic vision without doing all these kind of extra exposures, particularly for tumors, not for vascular. Vascular, of course, is a different cup of tea. I must, invite Mario to look at one of my papers, which I published 20 years ago about midline approach to foramen magnum meningioma. Mario, have you gone through that paper? And
yeah,
I must tell you, since I published that article 20 years ago, I have never for any kind of foramen magnum meningioma, recently I published in World Neurosurgery, ossified meningiomas located right in front of the brainstem. Even for those tumors, I have not done any kind of condylar resection or lateral exposure, midline exposure. and going lateral, respecting the arachnoid, respecting the vessels, using your technique of dissection, using your micro dissection techniques. So essentially, exposure is necessary, but to do over more than necessary exposure, I think sitting position should be considered.
I think we're losing you, Atul.
You're cutting out there, Atul.
Quite a bit of world you see.
Atul, I'm sorry.
Yeah.
I think we'll give you a chance for the internet to come back. I see Vladimir has joined us. Do you have a comment, Vladimir?
I would like to.
Yeah. Now you can hear.
Oh yes,
now you can hear better.
Yes.
See, the thing is, I'm not sure why sitting position is not used in so many other countries. I think there is an opportunity, like Ugur Ture is talking about sitting position. He's organizing one big conference on the subject. I think there should be resurgence of this approach. This is my feeling. Sitting position.
I agree with you. 100%.
Thank you.
Thank you. Vladimir,
I would like to make a few comments. I'm not doing this in a sitting position. Sitting position for me is supra-infra only. If you have a patient prone, you can incline the table and you really get any angle you need. But we were talking two kinds of lesions here. One kind of lesions are the tumors, which are extra nervous, like meningiomas. They provide the space for you, so you do not need any vertebral artery transposition. I did it probably 10 years ago last time, the same as Imad. And then there is the second kind of lesion, which are not moving the nervous system, like aneurysms and like cavernomas. There you may need a little more lateral extension. But anyway, even in this case, you do not need to resect that much of a condyle, because you can do all the work either above or below the condyle. It's not so difficult. So I resect probably 10% just to have free space there. Nothing really extensive. Never needed any stabilization and never having problems. The trick for the higher positioned lesions is the skull base of the occipital bone to resect it flush the same way as you do it with subtemporal approach. If you have this plane really flush with the skull base, then you can reach anything. And the second good trick is that usually you combine it with partly telomeral I would say, that you move the tonsil and then you get enough space for almost anything. And I was asking these questions many times. I never have seen meningioma which would be directly in the midline in front of the spinal cord or in front of the stem, so that the stem would be like a rainbow over the tumor. Did anyone see something like that?
Yeah, if I can, if I can share my screen, because you probably did not see the case that I showed, that had a small meningioma that was just in front of the brainstem without any, really, see, let me show it to you here. Yeah, am I sharing the screen or? Yeah, I'm screen sharing. Yeah, you see that, Vladimir?
Okay, so that is the first one I ever saw.
I know that.
Great. I missed that you selected one. This is really the first one.
Yeah, but that's my gift to you.
Mario, the spine, the nervous system is not like a rainbow. It's still in its place. So you can get there. Because it's
but that one was very small. So as you can imagine, I had a lot of folks that said, well, you have to go transoral and do this and do this other. And
no transoral for intradural lesion. But this is the same approach like for, let's say, vertebral junction aneurysm.
Absolutely. And so
that
we did it in the semi-sitting position with just removing, as you said, the horizontal portion of the occipital squama all the way to the cervical junction, because that's the key. If you don't remove that, you have a big piece of bone that prevents you from seeing.
Right.
Yeah.
Right. but not the condyle. You do not need condyle.
No, the condyle, I stopped really. I mean, at least in my practice, I have not found it necessary to remove the condyle. I used to do it many years ago. We used to do all this aggressive thing, you know, removing the condyle, mobilizing the vertebral artery, and mobilizing the vertebral artery is associated with a significant amount of morbidity.
Yeah, not anymore. I'm drilling always a bit, you know, just to show the residents where the condyle is and how to drill it. But it's insignificant.
Yeah.
Thank you very much. And if you don't mind, we might, I don't know if Henry's still here, we'd like to take a question from YouTube. So for those of you joining us on YouTube, Pablo Gonzalez has been monitoring the chat and he's picked out a question from there. So if Henry's still here or from any of our skull-based surgeons, the question is from Prasant Singh, and he asks, if you're drilling in large CP angle tumors, would you drill the IAC before decompressing the tumor?
Yes, usually yes, I do that. Except when the tumor is so big that the bony posterior wall of the internal arterial canal is covered by tumors. And of course, you have first to resect the tumor. I like it to find the facial nerve very early. So I expose it in the canal, and then you find the facial nerve very, very nicely.
Excellent. Thank you very much.
But sitting position.
Sitting for schwannomas, of course.
Lots of fans of the sitting position. Thank you very much to all the speakers. I'd like to hand back to our chairman, Professor Dr. Imad Kanan.
Thank you. Everybody. I think we are over time. It was a wonderful day and very impressive presentation, initiated a lot of discussion and values for the trainees. Tomorrow we have another exciting day. Professor Vladimir will run the show tomorrow. And we have many good speakers and presentations. So join us tomorrow at 12 Greenwich Mean Time. I don't know, you calculate it for your time. The other things, the form for evaluation will be distributed after tomorrow. So by that time, all the lectures are given. We depend on the attendees' evaluation and feedback to adjust our webinar to the benefit for them and the young practicing neurosurgeon. Thanks all the speakers and thanks to moderator. And Vladimir, you want to say some words?
Well, I just must excuse myself that I was not present for the whole program, but I had an AVM in the morning and it took some time to resect it. So I'm sorry, but from what I have heard, it was really excellent. Henry, perfect. Mario, the same. I have seen part of Victor's lecture. It was again excellent. And it's always good to see friends like Pablo and Ramesh and Sanjeeva. Great program, Imad.
Thank you. I told them that I excuse you because you have that AVM, but I told them you will do it with your backhand, you will be with us. So you managed to join us.
I managed to see bits and bits.
Okay, well, have a good night. Yeah.
Thank you, Imad.
Thank you. Thank you. Thanks.
See you tomorrow. See you tomorrow.
See you tomorrow.
See you tomorrow. Take care.
Bye bye.
Ciao, Giovanni. Bye.
A domani.
A domani, domani. Ciao. Ciao. Ciao.
Bye, Ramesh, Sanjeeva.
Pablo, should we check Ramesh is still awake? He's awake. Good. Okay.
I thought it was a picture.
I'm awake. I wanted to check if he was still awake.
I'll be back tomorrow. I had to do things in between.
See you tomorrow.
Okay, take care. Bye-bye.
Thank you,
Bye-bye.
Sanjeeva. Thank you.